Ma'am, please start in 3, 2, 1. Please start, ma'am. We are live.
Namaste and good evening, everyone. A very warm welcome to today's webinar on Clinically Update in GI Cancer. We are delighted to have all of you with us this one-day live webinar, where leading experts will share their valuable insight on the evolving landscape of oncology. Now it's my honor to invite our program convener, Dr. Satish Siti, Senior Consultant Medical Oncology, SCG Bengaluru. Dr. Satish Siti, it's over to you, sir.
Okay. Good evening, everyone. Thanks for the introduction. And today is we're going to have the wonderful meeting on the update on GI cancer. We have esteemed faculties. They have a lot of experience in treating GI cancer, and we have the molecular pathologist also is going to enlighten on the biomarker in the GI cancer, and we have the eminent speaker is going to talk on the stomach topic on stomach cancer. A lot of upsides are there, and definitely we have a lot of changes, updates are there, and on the treatment management of liver cancer and pancreatic cancer. And we have a wonderful, we have a the discussion is going to lead by our senior oncologist, actually, Dr. Murali Subramanian. We are going to have a good scientific discussion, and we are going. This meeting will definitely is going to helpful to have an exchange of the practical knowledge, and every individual consultant they have a different perspective when they are taking the data, dissecting into. They have they may take it positive, they may have a negative, and the experience may be different. Actually, every the patient outcome may be different. Actually, let's hear from every the faculty and their practical the experience also. Let's have the wonderful discussion also. My request the molecular pathologist Sandhya is she is going to talk on the biomarker in the GI cancer. Over to madam. Thank you.
Thank you. Thank you so much, Dr. Satish. Hi, esteemed faculty and the delegates in this talk. So I will be talking about biomarkers in GI cancer. Will the tech support be sharing my presentation, or should I be sharing my screen?
Wait, ma'am, I'll share.
Perfect. Yeah. Okay. Thank you. Thank you so much, dear. So if it's full screen, I'm unsure if people can view it well. Perfect. Perfect. Yeah. Hi. Hi, team. I am Dr. Sandhya Iyer. I work as a principal scientist, clinical genomics at OneCell.ai, and the presentation today would be on biomarkers in GI cancers. So next, yeah. So who we are, I'll just brush through quickly. OneCell is not a new name in the industry precision oncology today. We have been in service for over 24 months, catered to over 30,000 patients in different forms in precision oncology. We have publications with ASCO, AACR, ESMO, ISLB, and the count only keeps increasing. We have over 10 abstracts in 2024, similarly over 10 in 2025. And if you go ahead in the year 2026, we have over 19 accepted abstracts as we speak today. You can keep skipping the presentation, dear. Is it easier if I do at my end? Yeah, we have over 19 abstracts that have been accepted for ASCO 2025. And if you see the scoping of the kind of work we do, it is majorly with a lot of single cell circulating tumors, liquid biopsy beyond blood, and charting the entire transcriptional and translational landscape of precision oncology. That is the kind of work we do. Can we move forward? Yeah, move forward, yeah. Yeah, so our product portfolio basically caters to a wide range of solid tumors and everything. We have the small gene panel or the limited gene panel that can be used at the early stage of cancer management to the most aggressive cancer stages where multi-omics and a comprehensive genomic profile kind of portfolio is required. Beyond that, we also offer solutions for minimal residual disease monitoring, using longitudinal enumeration of both circulating tumor cells, CTCs, as well as ctDNA. You can skip further here. Yeah. So coming to the topic today, which is gastrointestinal malignancies and the biomarkers that are there. So if we all know that GI malignancies rank, they are one of the most prevalent and lethal, representing about 20% of all cancer cases worldwide. The overall burden is increasing and the mortality rates are also increasing and is responsible for 1 in 4 cancer cases and 1 in 3 cancer deaths. Next slide, please. So it is important to identify the gaps and understand the areas for progress, right? Biomarker testing, we know today has transformed cancer care, right? From single gene testing to multiple gene testings together, advances in molecular diagnostics, NGS technological improvements that have happened with the advent of AI and data sciences. Today, biomarker testing has become very easy with improved TAT and availability and accessibility as well, right? There is a lot of real world evidence that is also being gathered across cancer types. Pan cancer studies are there today, which talk about multiple cancer pathways that seem to be triggering, that are basically involved in the initial stages of cancer, and how the entire molecular landscape of the cancer changes as the cancer progresses, right? The third and the most important thing that comes to is, change the slide. The quality of the comprehensive testing remains the concern, right? It is usually the concern for a molecular oncologist or a treating oncologist that if I give the sample, same specimen to 2 different laboratories, are they going to be able to chart the same kind of molecular biomarkers for me? So the quality and the comprehensiveness is always a question because there is a lot of technological challenges and technical challenges that have to be met. The next is the gap that is majorly important is treatment delays and suboptimal selections are common, right? If a comprehensive genomic profiling is very expensive or is very time consuming, the only way moving forward is to test for that 1 or 2 biomarkers that the guidelines speaks about, leading to suboptimal selection because a lot of area becomes uncharted. And there is an opportunity to align practice with the best standards. That opportunity gap is what we are trying to fix today. Next slide. So the 4 pillars for a comprehensive genomic profiling that we are speaking about is, the first one is, you can just click, customizing the gene panel to understand that the biomarker assay today has moved beyond single gene testing. We have a lot of immuno-oncological markers. We have MSI, we have TMB, we have HRD, LOH, TAI, LST, and the list goes on, right? So constant technical optimizations are required. Customizing the gene panel as per the need and requirement is very important. Optimizing on the TAT becomes very important, and having an efficient bioinformatics pipeline. All these 4 are the key pillars that ensure that your CGP is becoming a hit product in the market, right? So all 4 is our pillar as well at OneCell.ai. Next slide, please. Next slide. So should routine genomic profiling be done in GI tract cancers? It's a very key question that requires an answer, right? Go to the next slide, dear. So you can click the entire slide, so it becomes easier for me to walk through. So the landscape of GI cancers has been studied. If you see, this is a very recent publication of the year 2021. In 603 patients, the entire landscape of genomic profiling was done with tumor normal sequencing, right? This study identified about 400 plus actionable targets, with APC, KRAS, CDKN2, and PIK3CA being the major. The pathways being impacted are the Wnt signaling pathway, which gets impacted when there is an APC mutation, cell cycle regulators, and the PIK3 pathway, which is majorly concentrated in the colorectal cancer. Clinically relevant, if you find HER2 mutation, the study found in about 4%, HRR gene altered about 30%, and KRAS G12C classic in about 7% of the cases. Immunotherapy associated, if you see MSI high and TMB high enriched, majorly in colorectal and gastric cancers, and actionable fusions were found in FGFR and novel in NRG1 mutation. Further, another study, which studied a total of 2,000 plus plasma samples across Asia and Middle East, identified there is a different, the entire molecular spectrum, if you see, there is a lot of overlap. If you see pancreatic adenocarcinoma, you have the classic KRAS and the HRR mutation. Similarly, in colorectal cancer, you have the RAS pathway and ERBB2, while in biliary tract cancers, you have fusions and BRAF, while in gastric, you have again the HER2 amplification. All through, MSI status becomes very important. And that is how the entire spectrum of molecular landscape is distributed in GI cancers as per scientific publications which are there. Continue. Next slide. why is your molecular testing or biomarker testing very important in gastric cancer is because apart from it identifying the drivers and therapeutic options, it is also going to help you in molecular subtyping of the cancer. So how can you determine the molecular subtyping of the cancer is that if there is a genetic alterations, it could be because of chromosomal instability, which is causing about 50% of the cancers in intestinal type. It could be genomic stable about 20%, which is the diffuse type. There could be microsatellite instability and the EBV positive. So each one has got a different molecular landscape that classifies the subtype, and they have different therapeutic implications also, right? So if there is a HER2 amplification, it becomes eligible for trastuzumab as well as MET or EGFR inhibitors, depending upon the pathway that is active. Similarly, if the MSI-TMB is high, we have FDA approval for pembrolizumab and nivolumab. And if the PIK3 mutations are positive, there is a scope to add PI3K inhibitors. So this molecular classification and subclassification of gastric cancer also becomes possible when you have a comprehensive genomic profiling done. Next slide, dear. If you see another study which has been published in the NCCN itself, biomarker assessment for gastric or gastroesophageal, it says that MSI testing using PCR or NGS or MMR using IHC. Apart from that, you need the HER2, PD-L1 and Claudin testing, and considering of NGS at the time of diagnosis or metastatic disease and other tumor agnostic markers are also important. So if you see the biomarker recommendation which comes from NCCN has got multiple biomarkers that are added. So what happens if you do a serial testing versus parallel testing is that because the tissue is going to be limited, the expanding list of biomarker testing becomes impossible after a certain point of time when you have a single tissue. So having a comprehensive genomic profiling where you have the tissue plus the blood ensures that a single multiplex test and multi-analyte test will give answers for all the biomarkers that are guideline recommended, ensuring that treatment from day one is guideline recommended and as per the standards. Next slide here. So another study which talked about real world genomic profiling in advanced gastric cancers, if you see, it's a panel based CGP test. 4634 patients with advanced gastric cancer were subjected to hybrid capture technology based NGS. If you see in this case, targetable or subgroup analysis was done, age less than 40 and more than 40, and MSI, TMB and EBV status was also used to classify. Targetable, they found about ERBB2 amplification in 9%, MSI high and TMB high and about 4 and 5, HRR mutations majorly in ATM and BRCA, and fusions in NTRK and the classic BRAF V600E and KRAS G12C. Further, they also found that CDH1 alterations were higher in patients who were less than 40 years of age versus more than 40, but MET amplification was also found to be higher in patients less than 40 years of age versus more than 40. So indicating that age, MSI TMB existing could also clearly differentiate your molecular signature in GI cancers. Further, dear. Now, when it comes to colorectal cancers, there is a different type of molecular signature itself that comes. So CRCs carry a continuum of molecular alterations, and the right-sided colon cancer and left-sided colon cancer, there is a distinct molecular pattern that comes in. Can you click, dear? So in this study that profiled over 10,000 CRC cases, the left colon, right colon or rectum, the tumors revealed distinct molecular patterns. So if you see, there is a RAS, MSI, BRAF, PIK3CA, PTEN in one side, while there is RAS, HRAF and HER2, TP53 in the other side, while the rectum cancer itself has a different set of molecular signatures. So having this comprehensive, right-sided showed high MSI and EGFR pathway, including BRAF and greater mutational burden, while you can click. The rectal cancers were enriched in HER2 amplification and TOPO1 expression. So this differentiation as per anatomical site of the cancer also plays a very important role when you try to understand the implications of the molecular biomarkers therapeutically. Mismatch repair deficiency was also studied in across 12,000 tumors, and they were identified to be deficient in 24 out of 32 tumor subtypes. And MSI status determined by NGS was done across cancer types. And MSI high offers a distinct data for treatment selections by ICI, in addition to TMB and PD-L1. Can you click? There is a graph that comes. Yes. So if you see across cancer types, if you see gastric adenocarcinoma, in the early stages, the MSI expression kind of wanes. And then in the later stage of gastric adenocarcinoma, late stage, it kind of progresses ahead, the MSI status. So that is why mismatch repair deficiency study by NGS becomes more important, because MMR using the classical IHC that only caters the 5 or 6 genes kind of fails to identify the other methylation impact of the genes on the MSI expression. That is what is missed when you do the classic IHC. Can you go to the next slide, dear? So if you see progression-free survival and overall survival also, comparison between CRC and non-CRC with mismatch repair gene, if you see, was not significantly different in patients with colorectal cancer as compared to other cancer types. It's almost like matching. When it comes to GI malignancies, you have to identify there is a predictive biomarker. So what can be for hepatocellular carcinoma having MSI and NTRK? For biliary tract cancers, it can be the IDH1 status, TMB and NTRK fusions. For pancreatic, specifically BRCA and PALB2 HRR genes. For esophageal cancer, it could be HER2 and MSI status. For gastric, again, HER2, TMB and NTRK fusions along with PDL1 status, very important. For colorectal adenocarcinoma, again, HER2, MSI. And if it is left-sided, then having the RAS wild-type status becomes very important. If RAS wild-type, they become anti-EGFR treatment can be given to the patients. Can you
Ma'am,
go
so
next
sorry
slide?
to interrupt in
Yes,
between.
dear.
Since short of time, please conclude in 2 minutes.
Yeah, I mean, I think this is the last slide. So detects, we need not go into the real life case. This could be the last slide. So some key points to identify is what does NGS or a comprehensive genomic profiling help doing? It detects actionable genomic alterations. Amplifications and rare fusions can be detected. MSI and TMB, which is genome-wide coverage, MSI and TMB becomes possible. Identifying resistance markers becomes possible because having EGFR and HER2 together, you know that EGFR inhibitors will probably not work single-handedly or HER2 will not act single-handedly because there are two multiple pathways working in the cancer together. And ctDNA can also be used as a longitudinal monitoring parameter for detecting MRD. So this is how we want to conclude that the biomarkers of GI cancer. Yeah. Thank you so much for your time. Yeah.
Thank you, Dr. Sandhya, for excellent talk. See that, definitely you have gone through the journey about the genomics landscape and also the IHC marker also you are highlighted. Actually, it's a very good thing. Definitely that previously genomics was limited to some few cancer. If you come to the GI cancer, definitely the colorectal and cholangio, we say the NGS. Now stomach also not like we limited only few marker like that MSI, PDL1, HER2. Now the Claudin is there, you have highlighted all those things, and also NGS also you can expand it, and the extended panel CGP is definitely helpful for the cancer management. And just I wanted to ask, like definitely that cholangio definitely gives a lot of changing our treatment landscape and the thing. One thing is that just one question: do you conduct a Nectin and any TROP2 test in GI cancer and thing?
Right now we are in the phase of introducing it, but currently Nectin and TROP2 is not available commercially, doctor. We are doing some amount of R&D work with Nectin and TROP2, but commercially we are yet to launch it.
Okay. Thank you, Dr. Sandhya. I request, next speaker, Dr. Srinivas BJ, a senior medical oncologist practicing at HCG Bangalore. He's going to talk on unresectable hepatocellular carcinoma. How do you manage a first-line management of liver cancer by immunotherapy? Dr. Srinivas, over to you.
Thank you. Thank you, Dr. Satish, for giving this opportunity. So I think my slides are visible, I think, no?
It's visible. You have to put in a full the presentation mode.
Yeah. So good evening, everyone. So today topic is transforming patients' outcome with innovative therapy in advanced unresectable hepatocellular carcinoma. So liver cancer is, if we go to the epidemiology of the cancer, so we have seventh most cancer, the hepatocellular carcinoma, and fourth most frequent cause of cancer-related deaths globally. So these are the global incidence and the global mortality, which is almost fourth in the global ranking. So 45% of cases at diagnosis, liver cancer has spread to lymph nodes or metastasis to the metastasis will be there, and prognosis is very poor. And we see this clinically in and out in most of our clinical practice. So most of our patients will have almost distant metastasis. Almost 45% of them will have distant metastasis. Even localized tumor, it will be advanced localized tumor, not amenable to the local treatment by surgery. So most of them require a loco-regional therapy along with systemic therapy. And we can see here 5-year survival rate. If it is very localized, then it is around 13.3% compared to the distant metastasis, which is around 2.4%. The regional one with lymph nodes, loco-regional, it is there around 10.6% only will survive at the end of 5 years. So in India, the incidence is around 38,000 and odd cases as per the 2022 Globocon
Well,
data.
done. I'm sending it.
So deaths will be around 36,000 and odd, almost 37,000 in 2022. And male to female ratio is around 4:1, and median age is around 40 to 70 years of age, and frequency increases with increasing age. And incidence of HCC in cirrhotic patients is around 1.6% per year. 50% of HCC will have advanced stage BCLC-C and BCLC-D staging. So inflammation and immune regulation, if we go to the etiopathogenesis of this tumor, so immune and dysregulation are key contributors leading to HCC development. So it will be HBV or HCV induced chronic infection with inflammation and apoptosis, cell death. So there may be metabolic syndrome, which is more commonly we see than the infective etiology, and the chronic alcoholic abuse. So which was one of the most commonest maybe around 5-10 years back. But what we are seeing in our clinical practice is most of them are metabolic syndrome, non-alcoholic steatohepatitis, which causes cell death, cellular stress, which lead to immune suppression, immune exhaustion, missing tumor surveillance, proliferation, pre-oncogenic transition, with a lot of fibrosis, inflammation. The liver goes to cirrhosis, and there may be overexpression of CTLA4, PD-L1 inhibition of antigen presentation, which may ultimately lead to hepatocellular carcinoma. So these are the risk factors that HBV and HCV, chronic inflammation, cirrhosis, and HCC. These are the different alcohol, tobacco, aflatoxin, metabolic disorder like NASH, obesity, diabetes mellitus. Other risk factors like geography, autoimmune hepatitis, which autoimmune hepatitis may contribute to around 1 to 5% of the patients. So most commonly the viral infection, and recently the non-alcoholic fatty steatosis of the liver, which are maybe because of the diabetes, obesity, which we see commonly, which may lead to chronic inflammation, cirrhosis, and leading to hepatocellular carcinoma. So the most common etiology, so this is what we are telling, followed by viral etiology is almost 927 patients, 35.5%, followed by viral hepatitis B and C, and harmful effects of alcohol. So this is one of the largest multicenter study which evaluated about the etiology of hepatocellular carcinoma, and they concluded that the non-alcoholic fatty steatosis, that is metabolic syndrome, is more commonest cause of this tumor. So management of advanced unresectable hepatocellular carcinoma. So we have so many options based on the staging. Early stage, the ablation resection is most common. So we usually deal with when the patient is in the locally advanced tumor, that is well-defined nodules, preserved portal flow, service success, where we talk about TACE followed by systemic treatment, or advanced stage where systemic treatment is the most commonest option of treatment, or end of liver function, almost the compromised liver functions are there, then we advise them pay supportive care. So usually clinically most of patients come to us when we can offer them the TACE therapy with test therapy with systemic treatment or upfront systemic treatment followed by some local treatment. So that is what we see the clinical spectrum of this hepatocellular carcinoma. The early stage and all, they usually they go to directly to the gastroenterologist, and either ablation, dissection, or liver transplant will not come to us directly. Some patients after liver transplant, there may be recurrence of the disease, and the patient may come after the liver transplant. So these are the evolution of systemic treatment in advanced and unresectable HCC. So it was almost sorafenib for almost 10 years it was there, and then the 2018 we had lenvatinib and pembrolizumab, and 2020 it is atezolizumab bevacizumab combination along with double immunotherapy ipilimumab and nivolumab combination, and recently the 2022 tremelimumab and rolumab IO combination. That is what we have seen in largest spectrum treatment algorithm. So most of us know that sorafenib is full dose, that is 4 tablets a day, was very few people were able to tolerate. Then the non-inferiority study was there with lenvatinib, where it has shown that it is non-inferior, but most of them are tolerated, and this immuno and the VEGF inhibitor is the most commonest regimen we were using before the approval of this double immunotherapy which we are using. The combination of ramucirumab is one of the trial where the alpha fetoprotein is more than 400, that has shown some progression-free survival. Regorafenib, some of the patients, when there is a failure of all the treatment, then regorafenib is also one of the targeted agents TKA we offer the patient if they are not able to tolerate the other treatments. So this is the SHARP trial and REFLECT trial, where they compared the sorafenib with placebo versus the lenvatinib with sorafenib. We can see here the 13.6 month the median overall survival compared to 12.3 months of in the sorafenib arm. Response rate was there with 23% partial response. The hypertension, diarrhea, decreased appetite, and decreased weight were the more commonest treatment-related adverse events. Whereas the patients in the sorafenib had a more of hand-foot syndrome, which is the most commonest the patient used to reason for discontinuation, and most of us are able to give only 2 tablets a day or 1 tablet a day, not able to give the full 4 tablets, which was done, which the clinical trial has done that. So coming on to immune checkpoint inhibitor with anti-VEGF therapy, which came in 2020, and which most of us have a more clinical experience with this. This is IMBRAVE 150 trial with a local advanced unresectable HCC. Asia and excluding Japan and rest of the world were there. ECOG PF, macrovascular invasion and extrahepatic spread was the stratification factor, along with baseline alpha fetoprotein less than 400 or more than 400 with atezolizumab and bevacizumab combination 15 mg per kg, and atezolizumab 1500 mg compared to 3 sorafenib arm until clinical benefit or survival. So co-primary endpoint was OS, and key primary and secondary endpoints were overall response rate as per the RECIST criteria. So this is the results we can see here. 18-month overall survival, 12 months overall survival, all were superior compared to the sorafenib. Even the PFS were at different intervals were more common with significant p-value, and most of the patients were able to tolerate this combination, atezolizumab and bevacizumab combination. So we can see here the hepatitis B and hepatitis C, the viral etiology were with hazard ratio was around 0.51%. So this combination has not shown significant improvement in the non-viral subgroup. So it has shown improvement in the viral subgroup, but other non-viral subgroup it has not shown significant improvement. So, but this is this was not the pre-specified analysis. So we will come to the other regimen. So these are the side effect profile of this regimen: hypertension, proteinuria, and loss of appetite, diarrhea. So, and we have more clinical experience that bleeding is one of the factor we consider when we are selecting this regimen, especially the esophageal varices is there or not. So based on that, we decide our the regimen of choice. So coming on to immune checkpoint inhibitor, IO-IO combination. So anti-CTLA-4 acts lymphoid compartment to increase the number of T-reactive cells, and PD-L1 acts in the tumor microenvironment to prevent T-cell inhibition with enhanced and synergistic anti-tumor activity. It acts by reversing the T-cell exhaustion and allowing T-cell activation, respectively. Uh, So high dose tremelimumab combined with durvalumab results in initial burst of peripheral T cells in patients with NSCLC, and similarly in melanoma, the initial dose of ipi and nivolumab causes a proliferative burst of peripheral T cells, which is not repeated at subsequent doses. So based on this rationale, the tremelimumab and durvalumab combination with the tremelimumab of a single dose, it was done with subsequent only durvalumab at the end at the every 4-week interval. So this is the phase 2 study, including the STRIDE regimen. So where they have done the different dose regimen of the tremelimumab 75, 50, along with durvalumab, single durvalumab regimen they have compared, and they have seen that the durvalumab 300 with, tremelimumab 300 with durvalumab has more superior overall response rate and significant impact on the progression-free survival. So that is why this regimen was chosen in the Himalaya phase 3 trial, where they have done the 4 arms were there: STRIDE regimen with durvalumab, tremelimumab 1500 to 300 regimen, arm B monotherapy with durvalumab, and arm C sorafenib, and arm D it is a 1575 mg with 4 doses. So with significant OS was the primary endpoint for this trial. So we know that single priming dose was as per the phase 2 trial. So that is why this regimen was chosen, and 75 mg at 4 doses were also there, along with the durvalumab monotherapy, and all the baseline characteristics were well matched in both the groups. So we can see here the demonstrated a statistically significant improvement in median OS versus sorafenib. So almost 22% lesser death risk compared to patients who has received sorafenib, this is the first study to have a longer survival rate, around 30.7% compared to 20.2%. So almost 66% of the 7% overall survival events were there, compared to 75.3%. So at the end of 36 months, it was around 30.7 months overall survival compared to 20.2 with the sorafenib arm. So most of the subgroup were benefited, whether it is Asian patients or other country, except hepatitis C virus, hepatitis B, and other non-viral are also benefited. And even the irrespective of the PD-L1 status, whether it is alpha fetoprotein less than 400 or more than 400, most of the subgroups benefited with the tremelimumab and durvalumab combination. So overall response rate we can see here around 20.1% compared to 5.1% with the sorafenib arm, and median duration of response is around 22.34 months compared to 18.43 months with the sorafenib arm. And we know this regimen has a more immune-related adverse events which can manage clinically well, without much toxicity to the patient. So any grade 3 to 4 treatment-related adverse events were 25.8% compared to 36 with the sorafenib arm, and immune-mediated adverse event requiring treatment with high dose were around 20% with this regimen. And discontinuation of the study was seen in 5.7% of the patients. So most common, more than 10% adverse events were there, especially rash, pruritus, diarrhea, hypothyroidism were more common with this regimen compared to the sorafenib. So treatment-related hepatic or hemorrhage events with the STRIDE were 0.5 versus 1.1% with the sorafenib, and the AST or ALT elevation, which we see clinically without much of the bilirubin increasing most of the patients, and the hemorrhage is very less common, which is one of the criteria to choose this regimen whenever the patient is having esophageal varices because of the portal hypertension. So most of the patients we can use this regimen over the atezolizumab and the bevacizumab.
Sorry to interrupt in between, sir. In sort of
Yeah.
time, I request you to please conclude in
So
2
this
minutes.
is the last time. So this is the NCCN guideline, which also recommend category 1 recommendation, tremelimumab with durvalumab as a category 1 recommendation for first-line systemic therapy. So concluding, HCC is one of the most commonest cancer affecting the Indians, and non-viral etiology, that is non-alcoholic fatty liver disease, is the most commonest HCC in the current patients what we are seeing. Immunotherapy combination have shown better anti-tumor profile. Atezolizumab, bevacizumab has shown a new standard of care in 2020, and then the double immunotherapy STRIDE regimen, which improved overall survival over sorafenib and demonstrated almost 3-year overall survival rate. And this regimen seems to benefit across all subgroups, including non-viral etiology. And STRIDE was well tolerated with low rates of discontinuation and GI hemorrhage. So with this, I will conclude. We will discuss further.
Thank you, Dr. Srinivas. Excellent talk on the journey of the hepatocellular carcinoma. I think you started brief about from epidemiology, the management, all the things you have gone through. That now, if you have one question, because like I know that we are running short of time. That but STRIDE, where you prefer and where you use other regimen as per your practice, Dr. Srinivas. Do you have preference anything, or like we have options are there?
Yeah, esophageal varices is there. So then usually we include this regimen, and most of our patients will have a esophageal varices. Either banding will be done or come with hematemesis. Maybe around 10 to 20% of the patients we see clinically. So in those patients, I think we can use this regimen. And even the gastroenterologist or the hepatologist also feels that if you give bevacizumab, the chances of bleeding in the clinical course may be higher. So in those patients, we usually tend to use this regimen. Though there is no head-to-head comparison between these trials, we have to. We are experiencing more immune-related adverse events, but though it is clinically manageable, once we explain to the patient relatives about the immune adverse-related events, risk of that immune adverse events, I think based on the patient preference, we can take it up, I think.
Okay, thank you, Dr. Srinivas. I think we'll request our speaker, Dr. Rajiv Vijay Kumar. He's a senior medical oncologist practicing at BJS Hospital. He's going to talk on the real world evidence of atezolizumab and bevacizumab regimen in advanced unresectable hepatocellular carcinoma. After this talk, like we have that abstract session on definitely this confusion what we have to do. We have a interesting we have a panel discussion regarding what we have to do. Over to Dr. Rajiv.
Hi, good evening. Thank you, Dr. Satish, and thank you, Roche, for giving me this opportunity to talk here. Are my slides visible?
Yes, sir, it is.
Okay, so without much ado, let's.
You put in a PowerPoint mode, Rajiv. Full screen. I think down is there.
ಎಲ್ಲಿದೆ ಅಂತ ಹುಡುಕ್ತಾ ಇದೀನಿ. ಈಗ ಬಂತಾ?
Yes, yeah.
Okay, today we shall be talking about like the I Am Brave trial. We're talking about the chief trial, that is the real world evidence of Tecentriq and bevacizumab, that is atezo-bev combination in untreated hepatocellular carcinoma. So therefore, let's look at the real world cohort. What exactly do we have? We all know the I am brave. We've been brave enough to give atezolizumab. Now, in real world, does it actually match? That's what we're going to have a look at. Okay, so now atezolizumab is the first and only globally approved first-line treatment to deliver significant improvements across all the endpoints: overall survival, progression-free survival, and overall response rate. Like my dear friend Dr. BJ, he spoke about atezolizumab with I am brave. He spoke about the Himalayan trial and the STRIDE regimen in Durva family. And then afterwards, we have the Checkmate 90W, that is Nivo-AP combination. So when you look at the median overall survival, the largest median overall survival delta was observed in the I am brave 150, as well as the highest percentage reduction in the risk of death compared to Himalaya and Checkmate 9DW. So even this is one important thing, like what we need to understand is when compared to what Himalaya and Checkmate 90W, we had large number of poor prognostic patients. Almost 14% were included in the I am brave 50. When we had the discussion with Durva Tremi, we realized that they had actually picked and chosen patients who were actually doing well. Whereas I am brave took all the bad patients with slightly worse PS and much more higher risk as well. So that is the difference. So in the Durva Tremi, that is in the Himalayan arm, there was no PFS benefit observed in both the Himalaya as well as the Checkmate. And then when you look specifically at the hazard ratios, look at the PFS hazard ratios. For Tecentriq Avastin, it's around 0.65, 0.9 for Himalaya, and again 0.87 for the Nivo-AP arm. So therefore, it is lesser when compared to I am brave. So, and then what are the practice-changing results? And what are the long-term survivals that we still see? So, I am brave 150 trial positioned atezolizumab as the first-line treatment for advanced hepatocellular carcinoma. We had limited follow-up data. You can see here that with time, the curve started separating and the patient started doing well. Let's have a look into the value of the real-world data. So, the real-world data complements the randomized control trials by evaluating different treatments in a broader population. Randomized control data is in a tightly controlled. All of us know that you have to have these fixed protocols and patients have to have these inclusion-exclusion criteria. Seldom do we see that in our regular practice. We need to incorporate all patients, even if it is a child's book B, B7, B8, we'd be like, we can probably just push him. Probably he might respond. Child's book given B10, and we'll be like, let's just see whether he responds. So we do try. So therefore, let's look at what happened. So the real world data can confirm whether randomized controlled results are observed in daily clinical practice. They can give complementary insights. They can translate the randomized control findings into high quality evidence. So real world data are important to inform treatment decisions amongst clinicians. So RCTs, of course, are the trusted mechanisms. You have a clear hypothesis. You have a fixed, homogeneous, well-matched patient population, control environment. All the side effects, everything is taken into account. There's but fixed and somewhat inflexible condition. And you have standard treatment guidelines. You can't deviate. You can't dose reduce. You can't skip. You have to do those things at those necessary times. Whereas in the real world, your patient might feel sick, you have multiple problems. You might need to keep changing your treatments. You need to keep changing your doses, etc. So therefore, this is large, very complex. You really can't compare apple to apple. In the RCT, you can. In the real world data, you can't. So now let's look at the strong real world evidence base for the first line atezolizumab combination HCC. Since publication of the I am brave in Jan 2020, there have been almost 123 real world study publications world over, 7 meta-analysis, more than 100 case studies. The totality of the real world data, when combined with data from the randomized control, support use of atezolizumab as a first-line standard of care for patients with hepatocellular carcinoma, including those with high-risk disease. Let's look at how efficacious it is and whether it's safe for the first 4 key real-world data studies that support I am brave. So we have D. Castro et al. Then we have an AB real study, Rimini et al. And Ramaswamy et al. So we can look at this in the I am brave 150. All of these have actually matched it pretty well. You can see it in the Castro et al. Real world, Rimini as well. You can see that the minimum overall survival is between 15 to 16 months. although in the IMBRAVE we have around 19 months. 6.9 months of PFS in the IMBRAVE. Rest of the place it's around 8.7, 8.3, 4.3. So it's well matched. Overall response rate has been pretty good all throughout. It's been between 30% to Alpha-Sama close to around 27%. So we can see that all of these, they've been very well matched. Then, then comes the HEPATOR-LONG study, extended follow-up at 42 months of Atezo-Bev in advanced HCC. So this chief prospective study. So IMBRAVE positioned Atezo-Bev as a first-line treatment. So this is real-world data from the French chief cohort. They wanted to check the overall survival, PFS, and then the overall response rate in the French population, which is called the chief cohort. So they had around 33 centers. It was prospective multicentral studies. Between 2020 to 25, all the patients treated with Atezo-Bev in the first line were included. Patients with Child-Pugh-C and PCLCD were excluded. So even in our practice, we don't take Child-Pugh-C, although we do try sometimes, but more often than not, we fail. Overall survival and PFS were assessed using the Kaplan-Meier method. The objective response was defined as the presence of either a complete or a partial response. The impact of baseline characteristics, including, was analyzed using the Cox models. Okay. So and then when you look at this, we had almost around 4,500 patients included inside the study. The number of patients treated by Atezo-Bev in the first line were around close to around 900. They had, of course, excluded the bad patients. So total patients were around 880. You can see that patients had alcohol-only vices. Some of them were due to secondary to HCV or HPV. And then afterwards, you have NASH. And then afterwards, here the liver function was again divided as per Child-Pugh-A. Large number. You can see here Child-Pugh-A, 78%. Like in our practice, we do see around 25-30% of patients who are Child-Pugh-A, but most of them hit the Child-Pugh-B, Child-Pugh-B8 category. So that was probably around 15-20% in this particular study. So now the follow-up, the HEPATOR-LONG study at 42 months of Atezo-Bev in advanced HCC. You can see that the overall survival 44 months is 44%. So the median overall survival is coming up to somewhere close to 23 months. So the overall survival according to the Child-Pugh, it's natural. If you have a good child A, then afterwards these patients live longer. And if it's a child B, the patients live lesser. That showcases the survival problem. If you choose a patient well, child A versus child B, a very strong p-value. So the median overall survival is 27 months for Child-Pugh-A and 9.8 months for Child-Pugh-B. And then as per if you've taken it instead of Child-Pugh, if you've taken it as to the Barcelona staging, there again the p-value is not as very significant, 0.029. Overall survival was 27 months for BCLC-B versus 18.5 for BCLC-C. And then when you look at, if you take the third grading, that's the ALB grading, that is ALB is albumin-bilirubin ratio. Over here, when you say if it's a grade 1, that's actually a good, that's like a minimal amount of disease. These patients did well. It's a very significant p-value. The overall survival is not reached for grade 1. It is 15.9 or 16 months for ALB grade 2 and grade 3. Similarly, in the when you look at vascular invasion as a component, patients with vascular invasion had a poorer prognosis, around 16 months, compared to those without. When you look at the PFS was somewhere close to somewhere around 5.8 months. And so when you can have, you have to basically use these predictive factors like either Child-Pugh staging or BCLC or ALB, or look at the alpha-fetoprotein. When you look at the PFS again, according to Child-Pugh, we saw the OS in the previous slides. Now we're looking at progression-free survival. When you look at that, it is in Child-Pugh-A, naturally we expect it to do better, 6.6 months versus around 4.5 months in Child-Pugh-B. And then if you look at for BCLC, if you're looking at PCL, the PFS, there too it's 7.3 months versus 5 months for B versus C. So looking at the best response, so the best was seen as stable disease. 50% of the patients had stable disease. 28% had good objective response when they were treated with Atezo-Bev. So when you look at this also, it's got a very, very significant p-value. So what key figures have to be retained? At the end of this talk, What do I have to remember? Because all of these are numbers, statistics, graphs, and you're like, okay, at the end of it, you don't know what exactly we're seeing, which is better, what. Simple things for us to understand. In 3.5 years, 44% of the patients in overall survival at 3.5 years. So our long-term real-world data shows that nearly 1 in 2 patients are still alive at 3 and 3.5 years. That's a very, very good number. So when you ask a patient says, sir, how long will I live? It should be like 1 in 2 people are going to live at least for 3.5 years. 23 months of median overall survival. So the study confirms the results observed in the pivotal clinical trial. Overall survival of 22.8 months versus 19.2 months from the IMbrave. So again, around 880 patients were analyzed. So this is a very, very good real-world data that we have. The conclusions: this overall survival rates at 42 months. It is unprecedented in real-world practice. It reinforces the long-term durable benefit of Atezo-Bev combination in advanced HCC. Thank you.
Thank you, Dr. Rajiv, for taking a wonderful journey about the data about the atezolizumab and versus map real world evidence also. Really that and you are touched about other agent and the role also. Everything else you are taken like definitely the regimes are there, but we have a confidence like it has been used because the clinical trial data it comes in exclusively in the selected patients.
Correct.
Yeah, when you're going for a real world, definitely it gives the more confidence also, and even because we too worried about natalizumab versus data, we don't have long-term follow.
Correct.
That was a one thing worry, and we used to have a discussion. But I think this definitely is give the more confidence to us. All those things that can use this regimen also, because there is a high risk is there. Sometimes the each regimen we cannot consider in all the patients because we have a selection is also important. High burden disease, high risk case, because when we have the V4 criteria, we cannot use this on other regimen also, side regimen also.
Correct.
Okay, that's what. But at least give the more confidence to us all those things. That's what selection occasion also is important. Thank you, Dr. Rajiv.
Thank you.
Okay, thank you. I request next speaker for the abstract presentation, Dr. Pallavi. She is a senior resident in medical oncology in HCG Bangalore. I request Dr. Pallavi to present on the phase 2 data on neoadjuvant protocol in your presentation. Go to Dr. Pallavi. Are you sharing your slide or you require technical support to share?
I require technical support to share, sir.
Yeah.
Yes, ma'am, sharing.
Yeah.
Thank you for the opportunity, sir. So I'll be presenting CRITIC-2 trial. It's a multi-center randomized phase 2 trial of neoadjuvant chemotherapy followed by surgery versus neoadjuvant chemotherapy and subsequent chemoradiotherapy followed by surgery versus neoadjuvant chemoradiotherapy followed by surgery in resectable gastric cancer. Next slide, please. The background of study: evidence-based strategies improve outcomes of resectable gastric cancer. That includes perioperative chemotherapy, postoperative chemoradiotherapy, postoperative chemotherapy. But the compliance of postoperative therapy is low. Preoperative treatment offers better patient compliance, induces downstaging, and increases R0 resection rates. Next slide, please. The aim of the study is to identify optimal preoperative treatment while omitting adjuvant treatment by comparing 3 investigational regimens. The trial design randomizes into 3 arms. The arm 1 is received chemotherapy alone with 4 cycles of docetaxel, oxaliplatin, capecitabine, followed by surgery. The arm 2 received 2 cycles of chemotherapy with the DOC regimen, followed by chemoradiotherapy with 45 gray of radiation and 5 cycles of paclitaxel and carboplatin. Arm 3 received chemoradiotherapy alone with 45 gray of radiation with 5 cycles of paclitaxel carboplatin followed by surgery. All the 3 arms underwent total gastrectomy and subtotal Next slide, please. So all the 3 arms considered for total and subtotal gastrectomy with extended lymph node dissection with removal of more than 15 lymph nodes. Next slide. The major inclusion criteria was stage 1B to stage 3C resectable gastric adenocarcinomas with no distant metastasis, negative staging laparoscopy. The localization was the tumor in stomach or G junction with performance status of WHO 0 or 1. All the patients were more than 18 years old. The primary endpoint of study was event-free survival at 1 year. The secondary endpoints were patient compliance, time to event, overall survival, pathological response rate, R0 resection rate, complications or toxicity, health-related quality of life, translational research. The study duration was between 2017 to 2024, was conducted at Netherlands. The median follow-up of 40.4 months. The statistical consideration, it was pick the winner design, assuming 1 year event-free survival of 60% is unsuccessful and 75% is effective enough. The study needed 69 patients per arm. So the baseline characteristics of the study were well balanced across the treatment groups, although slightly more G junction tumors were observed in chemotherapy containing arms. Next slide, please. The results of study profile. The surgical resection was performed in most patients across all treatment arms. Curative intent surgery was undertaken in 60 patients in chemotherapy alone. 58 patients in the chemotherapy followed by chemoradiotherapy arm, and 63 patients in chemoradiotherapy alone arm. Next slide. The preoperative toxicity was acceptable across all the arms. Grade 2, grade 3 adverse events occurred in 52% of patients receiving chemotherapy alone, 53% in the chemotherapy plus chemoradiotherapy arm, and 43% in the chemoradiotherapy alone arm, indicating lowest severe toxicity burden with chemoradiotherapy alone. The type of gastrectomy was comparable across all treatment arms, with 47% undergoing total gastrectomy and around 43% undergoing subtotal gastrectomy. This suggests balanced surgical characteristic between groups. Majority of patients underwent D2 lymphadenectomy, ensuring fair comparison of chemotherapy versus chemoradiotherapy strategies. Next slide. Around 57% of patients achieved node-negative status after neoadjuvant therapy, suggesting good pathological response in all treatment strategies. The highest pathological complete response was observed in chemotherapy followed by CTRT arm, which was 20%, suggesting improved tumor downstaging with combined modality treatment. High R0 resection rates were achieved in all arms, indicating good surgical outcomes, irrespective of neoadjuvant approach. The event-free survival, the primary endpoint of first 1 year event-free survival clearly distinguished the treatment strategies. Chemotherapy alone achieved 1 year event-free survival of 68%, failing to meet the predefined efficacy threshold. In contrast, chemotherapy followed by chemoradiotherapy achieved highest 1 year event-free survival at 84%, while chemoradiotherapy alone reached 78%, both meeting criteria for sufficient activity. Next. The overall survival at 1 year followed a similar pattern with rates of 74% for chemotherapy alone, 89% for chemotherapy plus chemoradiotherapy, and 84% for chemoradiotherapy alone group. So considering survival, surgical complications, and pathological response rates, total neoadjuvant chemotherapy plus chemoradiotherapy is identified as a preferred preoperative regimen. Next slide. To summarize, CRITIC 2 compares 3 preoperative regimens without adjuvant treatment. Preoperative compliance rate was high and most favorable after chemotherapy alone and after chemoradiotherapy alone. Preoperative toxicity was lowest after chemoradiotherapy alone. Surgical quality was excellent with 91% undergoing more than D1 resection and removal of median of 25 lymph nodes. Surgery related complications were acceptable, being lowest after chemotherapy plus chemoradiotherapy. Next slide. In-hospital mortality was low, which was around 4%. Pathological complete response rate was highest after chemo followed by chemoradiotherapy group, which was 20%. Preoperative chemotherapy alone failed EFS efficacy threshold, while preoperative chemo followed by chemo-RT and chemoradiation alone were sufficiently effective. Considering survival, surgical complications, and pathological response rates, total neoadjuvant chemotherapy plus chemoradiotherapy is identified as a preferred candidate for further study. The limitation of study was pick the winner method compares investigational treatment arms separately. The current standard therapy was not a part of phase 2 trial. Standard therapy may change during long duration of patient accrual.
Sorry to interrupt, ma'am. In sort of time, I request you to please conclude in 2 minutes.
Last slide. The total neoadjuvant chemotherapy plus chemoradiotherapy appears superior compared to chemotherapy or chemoradiotherapy alone as a preoperative regimen for patients with resectable gastric cancer. Total neoadjuvant chemotherapy plus chemoradiotherapy is feasible and effective and may be a topic for further evaluation in context of organ sparing approaches.
Thank you, Pallavi. Like it is a one important thing research, like because chemo radiation used to do esophageal cancer at G junction. This is a study is going to even stomach cancer, operable cancer is going to have the data and comparing with the chemotherapy, even though numbers are low in phase 2. Okay, that other options, organ preservation can be tried. Some people they don't want surgery, there they can be explored. And I think the all the three options can be done. Only thing is that like if you have a compare with the chemo, with immunotherapy is one of the standard practice right now. They are not comparison not there, and for, we want a more number actually. That is the one thing you require. Furthermore, like the larger number of patient and a bigger study. Thank you, like Dr. Pallavi, and I request next speaker, Dr. Aditya, is going to talk on the that blocking the Claudin 18.2 that in the stomach cancer. Is going to talk on the abstract on how we have managed the Claudin positive advanced esophageal G junction cancer. Dr. Over to Dr.
Yes,
Aditya. He's a
Yes.
consultant medical oncologist practicing at HCG Hospital.
Yes.
Dr. Over to Dr. Aditya.
Yes, sir. We are here, sir. You can hear.
Yeah. You can
Yes,
put in
yes.
the presentation mode, Dr. Aditya.
Yes, sir. So I'm presenting phase 2 ILLUSTRO trial of first-line zolbetuximab plus modified FOLFOX6 and nivolumab in patients with Claudin 18.2 positive, locally advanced, unresectable or metastatic gastric or GE junction adenocarcinoma. So these are this will be told in the last. So background, first-line biomarker-driven therapy is a standard for patients with gastric or GE junction adenocarcinoma, and Claudin 18.2 is a validated target in 40% of the patients. In a pooled analysis of the phase 3 Spotlight and GLOW studies, zolbetuximab with chemotherapy improved PFS and OS, median PFS and OS compared with chemotherapy alone. So in preclinical models and treatment immune profiling, zolbetuximab plus chemotherapy showed synergy with PD-1 inhibition. So this is the triplet therapy with zolbetuximab, chemo, and PD-1 inhibition outperformed doublet therapy, Claudin 18.2 mouse models. So this phase 2 multi-cohort ILLUSTRO study investigated the efficacy and safety of zolbetuximab as monotherapy or in combination with chemotherapy and or with PD-1 inhibition. So actually, this study included many cohorts 1, 2, and 3. Cohorts 1, 2, and 3 were discontinued, but cohort 4 was the one which showed good results. So according to the key eligibility criteria, previously untreated locally advanced unresectable or metastatic GE junction adenocarcinoma were selected, which were Claudin 18 positive, with more than 50% of the tumor cells expressing Claudin 18, and HER2 negative, and with performance status, ECOG performance status 0 to 1. So cohort 4A was divided into cohort 4A and 4B. 4A was mainly to know the safety of the regimen, whereas 4B was an expansion phase for the efficacy. According to this, cycles 1 to 4 were given zolbetuximab 800 mg per meter squared along with nivolumab 240 mg with modified 446 regimen every 2 weekly. When cycle 5 onwards, zolbetuximab was given 400 mg per meter squared with nivolumab 240 mg and 5FU with folic acid every 2 weekly. So the endpoints analysis were PFS, overall response rate, disease control rate, duration of response, OS, overall survival, safety and tolerability. The statistical considerations, this was the cohort 4A was designed to assess dose probability in 12 patients, and cohort 4B, 65 patients planned, aim to include 50 patients with high Claudin 18.2 expression. Assuming statistical considerations were assuming 12-month accrual and 3 to 6 months follow-up, 20 to 25 PFS events were expected, and sample size was estimated to provide 78 to 76% power to detect a PFS improvement with assumption of median PFS of 12 months versus a median PFS of 8.5 months using a one-sided test with alpha error of 15%. So this is the how the study was conducted. For cohort 4A, 12 patients, out of the 12 patients in cohort 4, 6 patients received higher dose of zolbetuximab, and out of that, for 800 mg per meter squared was deemed to be tolerable and confirmed. In the expansion phase, that is cohort 4B, 71 patients were enrolled, out of which 39 patients had disease progression, 5 patients had were discontinued, and 3 patients had adverse events, and 1 patient had died. So PFS, OS, and where the endpoints were PFS, OS, and overall response rate. So the demographics in cohort 4A and 4B, the median age was 61 years. Most of the patients were male, and most of the patients were had Asian race. And patients had different treatments. Either surgery was performed earlier, surgery followed by chemotherapy, or chemotherapy followed by surgery. And most of the patients had ECOG performance status 0 to 1. With 0 to 2 metastatic sites were the predominant number of metastatic sites in cohort 4 and 4B. And a majority of the patient had PD-L1 status positive with CPS more than 1. So this is the PFS, median PFS in the cohort 4B, which was 14.8 months with zolbetuximab, FOLFOX6 regimen along with nivolumab. And PFS stratified by Claudin 18.2 expression. Those which have high Claudin 18.2, that is more than 75% expression, had higher median PFS of 18 months compared to intermediate, that is 6.7 months. And PFS by PD-L1 CPS, if those who had CPS more than 1 had higher median PFS of 23.6 months compared to patients with CPS less than 1. So median PFS was 23 higher in patients with PD-L1 positive patients. And the OS, in those with high Claudin, when Claudin expression was compared to the median OS, those with high Claudin expression, that is more than 75%, had non-available median OS, but it was not yet reached compared to 9.6 months in the intermediate subgroup. So this is the tumor responses. Overall response rate was 68.1% in patients with Claudin 18.2 high group, and the response was more with high expression compared to low expression. And this is the duration of response. So overall, median duration of response was 19.1 months, and in high Claudin 18.2 expression, it was not available, whereas it was 19.1 months in the intermediate risk group. And the safety profile, safety profile was manageable with no unexpected signals, and the median duration of treatment was 288 days for zolbetuximab and 226 days for nivolumab. and the median relative dose intensity of zolbetuximab was 97.1%, and nivolumab was 97%. And so the safety profile was manageable with a combination of FOLFOX, zolbetuximab, and nivolumab. So most common side effects were nausea, decreased appetite, decreased neutrophil count, and peripheral sensory neuropathy. And 50 or more than half of the patients had grade 3 adverse events in this cohort group, but it were manageable. So the most common adverse event was nausea, and all events were of low grade. So conclusions. Triplet therapy with zolbetuximab with FOLFOX and nivolumab led to encouraging PFS in ILLUSTRO trial. So the PFS was higher in those with high expression of Claudin 18, and it was the highest in patients which had expression of both Claudin 18 and PD-L1 positive, that is CPS more than 1, compared to those with less PD-L1 negative or intermediate and low Claudin 18 expression. And zolbetuximab with FOLFOX and nivolumab demonstrated acceptable safety and tolerability, with nausea and decreased appetite being the most common adverse events, treatment-related adverse events. So this triplet therapy approach, it was a promising strategy for patients with Claudin 18 positive, HER2 negative, unresectable and metastatic adenocarcinoma with PD-L1 positive patients. So these results, they have formed a design for next phase 3 Lucerna study. So this is the phase 3 Lucerna study where Claudin 18 and PD-L1 positive patients, instead of nivolumab, here zolbetuximab, pembrolizumab, and Capox or FOLFOX was given. So the results are yet awaited for this study.
Okay, thank you, Dr. Aditya. See that it's a sorry. You can conclude.
Yes, sir. So what was this research about? It was mainly about the Claudin 18 expression and PD-L1 expression, where triplet therapy showed promising results with advanced GE junction and gastric adenocarcinoma. And the patients had to be Claudin 18 positive, 18.2 positive and HER2 negative, unresectable or metastatic gastric or GE junction adenocarcinoma.
Thank you.
So phase 3 results are still awaited.
Yeah. This one thing is there, like see the Claudin one, basically generally we don't do the testing. We usually will do the PD-L1 MSI and HER2. This is one of the things, especially if you have a Lenitus plastica signet cell, definitely there have a very aggressive tumor. The Claudin positivity will be very high in that segment of tumor. Better, like, because their prognosis may not be good compared to other subsite and different type of stomach cancer. And please try to get the evaluation of Claudin positive, Claudin 18.2 there, and you can leave because drug is not available in India. We can get it like those are affordable. You can get it, and you can, those they want it desperately, they want to have a better outcome. We can have that, especially the Lenitus plastica is one thing you're supposed to do it. Thank you, Dr. Adhika.
Yes, sir. Thank you.
I request Dr. Krishna. He is going to talk on that role of dual blockade, that is blocking the HER2 and also with the immunotherapy or without immunotherapy. Is there any difference? Is there in the management of advanced stomach cancer? Is going to talk on the abstract is going to present. Over to Dr. Krishna.
Yeah, good evening, sir. Thank you, Satish sir, for giving me the opportunity. Can you please
I request
share the slides?
the presenters, because like we are running out of time. Please
Okay, sir.
try to complete on time. Thank you.
Okay, sir. So, everyone, now we will see about the Horizon GEA-01 trial, evaluating zanidatamab chemotherapy plus with or without tislelizumab, comparing with the trastuzumab plus chemotherapy in unresectable or metastatic gastroesophageal adenocarcinomas. Next slide. Next slide, please. Coming to the background of the study, The drugs used in the study are zanidatamab. It is a dual HER2 targeted bispecific antibody which binds to the domain 2 and domain 4 of the HER2 in a trans configuration. So by this, it will cause topic binding, which enables the zanidatamab cross-linking with the neighboring HER2 receptors, leading to the receptor clustering, followed by the HER2 internalization and reduced downstream signaling, and promotes immune-mediated cytotoxicity. And the tislelizumab is it's a PD-1 immune checkpoint inhibitor. It is specifically engineered to minimize the Fc gamma receptor binding on the macrophages. Next slide. So coming to the study design, the eligibility criteria are age more than 18 years, unresectable, locally advanced and metastatic gastroesophageal adenocarcinomas, and HER2 positive, IHC 3+ or 2+ with FISH positive, ECOG PS1 and 2, and no prior treatment and no prior HER2 targeted or immunotherapy. So total 914 patients were selected and randomized into 3 arms. Arm A, the control arm, that is trastuzumab plus chemotherapy. Arm B, zanidatamab, a dose of 1800 mg with the for weight less than 70 kg and 2400 mg for weight more than 70 kg once in 3 weeks along with the chemotherapy. And arm C, zanidatamab plus tislelizumab, 200 mg once in 3 weeks along with the chemotherapy of physician choice, that is Capox or 5FU plus cisplatin. And prophylaxis has been given to prevent infusion-related reactions and diarrhea, which is mandatory in the zanidatamab containing arms. And the chemotherapy was continued for 6 cycles, and once in 6 weeks, assessment was done with CT or MRI. The primary endpoints are PF, progression-free survival and overall survival. Secondary endpoints, objective response rate and frequency and severity of adverse events. Next slide. So statistical design, they used a fixed sequence testing procedure. So subsequent test will be only considered when the previous test is statistically significant. Next slide. So out of the total 914 patients were randomized, and the median follow-up was 2 years. So in the zanidatamab containing arm, the ongoing treatment patients were more compared to the control arm, that is trastuzumab arm. And the reason discontinued the patients, the reason for discontinuation was because of progressive disease followed by adverse events and death in all the 3 arms. Next slide. So coming to the demographics and disease characteristics and clinical characteristics were balanced across all the 3 arms. With a predominant male sex of 80% in all the 3 arms, and geographic region Asia population were 50% in all the 3 arms, 1 and 2, and metastatic cases more about 90 to 95% in all the 3 arms. And the anatomical subtype more of gastric cancers, around 70% in all the 3 arms, followed by the GEJ and esophageal, and HER2 3+ were 80% in all the 3 arms. And the PD-L1 positive more than 60%. And less than 1% were 30%. And majority of the patients received Capox regimen of 90% in all the 3 arms. Next slide, please. So coming to the primary endpoint, the showing the suppression of curves early with a median PFS of 12.4 months in the triplet regimen, that is zanidatamab, tislelizumab chemotherapy, compared to trastuzumab chemotherapy 8.1 months with a hazard ratio of 0.63 and significant p-value. So implies there is significant and clinically meaningful improvement in PFS with the zanidatamab, tislelizumab chemotherapy arm versus the control arm. Next slide. So the previous slide, please. Previous slide, please. So this comparing the ZAN. So coming to the OS, coming to the OS, improvement in OS across all the major specified subgroups, including the regions and PD-L1, irrespective of the PD-L1 TAP scores. in the zanidatamab tislelizumab chemotherapy compared to the control arm. Next slide, please. So the comparing the zanidatamab chemotherapy arm with the trastuzumab arm, the median OS was 24.4 months in the doublet arm versus 19.2 months in the control arm, with a significant improvement in OS of 5 months. Next slide, please. So coming to the secondary endpoints for activity, there is a confirmed objective response rate in all the arms, which was more or less 70%. But the complete response was almost double of the control arm in triplet regimen, which is about 19.6 versus 11% in the control arm. Was almost 3 times that of the control arm in the triplet regimen, that is zanidatamab, tislelizumab chemotherapy arm, 20.7 compared to 8.3 in the control arm. Next slide, please. The treatment-related adverse events were about of any cause were 90% in all the 3 arms, and grade 3 were more in the zanidatamab tislelizumab chemotherapy arm compared to other 2 arms. And the infusion-related reactions were about 25% in the zanidatamab arms, both zanidatamab arms compared to the trastuzumab arm. And the non-infectious pulmonary toxicities were more in the arm compared to other 2 arms. Next slide, please. So among the treatment-related adverse effect events, most common was diarrhea followed by nausea, vomiting, and the diarrhea was more in zanidatamab arms compared to the trastuzumab arm. And grade 3 was lesser, and grade 1 to grade 2 are almost 70%. Next slide, please. So among the treatment-related diarrhea, the grade 3 was around 24% in zanidatamab arms compared to the trastuzumab arm, and duration of the first event was around 14 days compared to 70 days arms versus 10 days in the trastuzumab arm. So there was a mandatory diarrhea prophylaxis was given for the patients in zanidatamab containing arms with loperamide 4 mg BD for the first 7 days of the cycle 1. Next slide, please. So discussion and conclusion, the containing regimens led to the clinically meaningful prolongation of PFS, which was statistically superior to trastuzumab plus chemotherapy. And zanidatamab tislelizumab chemotherapy demonstrated a clinically meaningful and statistically superior prolongation of OS also compared to the trastuzumab plus chemotherapy arm with the 7-month prolongation of median OS. So these findings support that is a agents with the potential to replace trastuzumab in the first-line treatments of HER2-positive metastatic esophageal adenocarcinoma. And this Horizon GA1 is the first phase 3 study in the metastatic GA to demonstrate a median PFS of more than 1 year and a median OS of more than 2 years. Thank you.
Thank you, Dr. Krishna. See, presenting on the role of dual therapy, because we had a data for trastuzumab single agent. We have a better molecule, that is the Gentamab. Then along with that newer molecule, that is a tislelizumab, that we have a data about the trastuzumab and pertuzumab that is being shown PD-L1 positive also. And this is definitely that in the same similar way that is having the longest better the outcome, disease control, all the thing appears to be very promising, especially phase 3 data. The only thing is the molecule availability of the anti-HER2 blockade is the one important. That has been very successful in the colorectal cancer and vestibular tract cancer, and also is coming in the first line in the GE junction and stomach cancer. Thank you, Dr. Krishna. And I request Dr. Amina. She is going to present on the adjuvant role with the SOX protocol in G junction and stomach cancer. Dr. Over to Amina.
Hello, can you hear me, sir?
Yeah, we can hear you. Yeah.
Good evening, everyone. Thank you, sir, for the opportunity. I'll be presenting Capital Trial. It is a randomized open label phase 3 trial in which we compare adjuvant oxaliplatin with S1, that is SOX regime, versus S1 in patients with stage 2, stage 3 gastric or gastroesophageal junction adenocarcinoma. It was done by Ran Kong Neil et al. The diverging oncological principles and trial evidences have led to fundamentally different region-specific standards of care for resectable gastric or G-junction adenocarcinoma, thereby creating a clear east-west dichotomy in clinical practice. In Asia, adjuvant chemotherapy of 12 months of S1 or 6 months of CAPOX after D2 gastrectomy is widely used as the standard of care for stage 2, stage 3 G-junction or gastric adenocarcinoma. However, there is room for improvement, especially for S1 monotherapy. So it is also expected that the combination therapy with either oxaliplatin or docetaxel plus S1 may further improve the efficacy. Hence, this Capital trial is a phase 3 study which was done to evaluate efficacy and safety of oxaliplatin plus S1 for post-op stage 2, stage 3 gastric or G-junction adenocarcinoma after D2 gastrectomy. Come to the study design, it was a phase 3 randomized open label control study of Asian patients, mainly from China. And the eligibility criteria being ECOG performance status 0 to 2, age around 18 years or older, with post-op stage 2, stage 3 gastric or G-junction adenocarcinoma with D2 gastrectomy. So around 729 patients were randomized 1:1 ratio into 2 arms. First arm received adjuvant oxaliplatin plus S1, that is a SOX regime, for 6 cycles, followed by S1 for 10 cycles. Here the oxaliplatin dose was around 100 milligram per meter square, given on day 1, which was given 3 weekly once. And S1 dose was around 40 milligram per meter square orally twice daily, given from day 1 to day 14. So in the second arm, the S1 alone was given for, adjuvant S1 alone was given for 16 cycles. Patients were randomized from October 28, 2011 to November 3, 2017. Primary endpoint being overall survival and secondary endpoints were around disease-free survival and the safety. Patients were randomized, patients were followed up for a minimum of 60 months. Coming to the baseline characteristics in both groups were almost comparable. Age less than 65 years were around 50% seen in the SOX group, whereas around 43% in the S1 group. ECOG performance status of 0 was seen in around 98% in both the groups. So tumor location, around 79 to 80% were around gastric adenocarcinomas, and 21 to 19% were gastroesophageal junction tumors. And post-op stage being majorly that is T3, T4, around 86 to 88%, whereas nodal post-op nodal status being N2 to N3 in around 69 to 61% patients was seen. And according to Lawrence classification, the diffuse histological type was seen in around 46 patients in the SOX group, whereas 41 patients in the S1 group. Intestinal and mixed variety was seen in around 37 patients in the SOX group and 43% in the S1 group. Signet ring cell composition was seen around 30% in the SOX group, whereas 26% in the S1 group. Coming to the primary endpoint, which was overall survival, statistically significant improvement was seen in the overall survival, as you can see in the Kaplan-Meier curve here, where in the adjuvant SOX arm, 5-year overall survival being 70.9% in the adjuvant SOX arm, whereas it was only 62.9% in the S1 alone arm. And hazard ratio being 0.74 and p-value being 0.018. And this overall survival benefit was observed in all the key subgroups, which you can see, which favors in this forest plot, you can see favors the SOX arm, adjuvant SOX arm. And coming to the secondary endpoint, which was disease-free survival, it was disease-free survival benefit was also seen in the adjuvant SOX arm. Here, that is 5-year DFS is around 66.2% in the adjuvant SOX versus 55.6% in the S1 alone arm. Hazard ratio being 0.76 and p-value being 0.021. Coming to the site of first relapse, this adjuvant SOX reduces the relapses, and particularly the locoregional relapse, where you can see the total number of relapses is around 24% in the SOX group, which is a significant reduction, where it is 31% in the S1 group. And locoregional relapse is only 2% in the SOX group, whereas 7% in the S1 group. Coming to the most common side effects, treatment-related adverse events were a little bit higher in the SOX group, around 85%, whereas it was around 75% in the S1 group. Most common adverse events were around was anemia, neutropenia, leukopenia, and thrombocytopenia, and AST, ALT elevation, and peripheral neuropathy, which were seen a little higher in the SOX group. Coming to concluding the trial, what we observed is the addition of oxaliplatin to S1 chemotherapy significantly improved the overall survival and disease-free survival in patients with stage 2, stage 3 gastric or G-junction adenocarcinomas. So the overall survival benefit was also consistently seen in the key subgroups, and the treatment-related side effects were manageable. Thus, CAPITAL trial supports the SOX regime as a standard of adjuvant therapy for Asian population following D2 gastrectomy, as it significantly improves both overall survival and disease-free survival compared to only S1 alone. Thank you.
Thank you, Dr. Amina. It is an excellent talk, like adjuvant role, because we have a Capax regimen tolerance is a very major issue with the capecitabine. This Saxon regimen definitely I've been used actually is a very is tolerable compared to Capax. I don't know that the different consultant may have a different experience, but it's a good regimen like we that has been already used, and sometimes we cannot able to go with the 5 if you look over in actually that you can use the S1 is easily actually with the oxaliplatin. And also you have almost a 5-year data because very significant. You can try to use in the different subtypes of stomach cancer. It's giving the good confidence actually. The hand-foot syndrome and a lot of tolerance is a major issue with other like a Capax regimen. That's what we used to try to use. Thank you, Dr. Amina.
Can I just make
Yeah,
a point?
Rajiv, yeah.
Hi. I'm just
Yeah.
trying to ask, like, in this present day and age, like, we see that stage 3 is also been included into this particular study, but most often than not, we would end up doing chemotherapy upfront and then followed by surgery for stage 3 in this, because this is probably from probably previous era, which was there. So after doing 4 cycles FLOT, and then after you have the surgery, you done the surgery, you have a PT1 or PT2. Would you give 4 more cycles of FLOT as per the standard, or are you okay to switch over to SOX?
Yeah, definitely that now perioperative regimen has come stage 3, like a high risk, like stage 2 also. See that this study was done in 5 years ago, 5-6 years ago, and you have almost a data 5 years survival data, all the thing. This is a good thing. Actually, before the immunotherapy era, all the thing. Now the era of immunotherapy, but we don't have a good backbone chemo regimen also. Yeah, in the flat we love to do it, but problem is it may not be able to practice in all the patient tolerance issue. Even the capax also is not easy actually. That capecitabine is very challenging. I think that like I've been using actually this is a SOX one with immunotherapy. I mean already started using actually
The
the using
flot,
it.
you did 4
Uh,
flot, then surgery. After that,
After that again 4 more flot.
Raj,
Four more
Rajiv,
flot regimen adjuvant will be done.
I can come. Rajiv, yeah.
Hi, Vijay.
So I think post-op flot will be difficult. So I
Correct.
would agree that I would go with an S1 ox in that situation.
Those were
So post-op flot will be difficult. Yeah.
Nice. All right. Thanks.
Many times it may go with either a Folfox or sometimes Capax like and that this is the easy regimen. We can use a SOX also one of the things that we can use it tolerance. But one thing is very important here is SOX regimen that you are to completion of 6 cycle. You are continuing a S1 for almost like a total 1 year treatment. That is one important actually. Okay. Anything question like Rajiv?
Yeah, basically it's like it's actually a good idea to continue S1 for a year. In sense like somewhere like a triple negative, where you continue it for 6 months. Some people give it for a year as well, lower dose. Giving S1 for a year or two, I've been doing this and I found fantastic results. 2 years, even if it's D3 N3 disease also, they are disease free even after 2 years. So I find that to be very, very nice. Low dose 20 mg BD of S1, fantastic results.
Yeah, that the tolerance definitely I don't know. That's what I've been using this S1 SOX trial that using not only stomach in a pancreas also I'm using in a colorectal also sometimes. Yeah.
Yes. All three. Anywhere hepatobiliary.
Yes. Okay.
Thank you.
Yeah. And because of we are running out of time
Yeah.
actually, that this is one of the this talk actually that I have to speak. This is the bridging gap between in the management of pancreatic cancer with liposomal irinotecan. If we come into the introduction, we know that this various cancer is there. Like if you see that the more than 1 million new cases of digestive cancer seen in the Europe, pancreas almost like 146,000 cases per annum. You can see that this is the geographic distribution of pancreatic cancer in the globally. You can see that the different like in American countries, Europe and Asia, all the thing. But the estimated the pancreatic incidence definitely come from 2020 to definitely 2040 year. Definitely you are going to see the more number of new cases also, and the same like the death also you are going to see more. What are the objectives like today's like talk is like this like goal in the management of advanced pancreatic cancer is improve that survey. Yeah, definitely we love to do that, but it's practically challenging, not easy. And PFS also we want to control the disease. Definitely the improve quality of life, and the maintaining the nutrition is really not easy actually. They're already cachectic in the pancreatic cancer, and obviously that quality of life including the pain management, other things with the least side effects. This is a slide showing the evolution of the pancreatic cancer, how it started in the with a single agent gemcitabine when compared with the 5FU was a old standard treatment before that, and lot of the combination regimen compared to the single agent. Gem Erlotinib, Gem 5FU, the platinum based treatment, and Gem Nab-Paclitaxel has come, and now later like Folfox or Capax like that, and even Naliri regimen actually. That's what where the liposomal irinotecan with the 5FU look over in 2015. You can see that modified Folfox, like you can see then Folfirinox, various regimen has come, then now novel drugs, and even trying even immunotherapies also, and role of even the Olaparib maintenance in the BRCA positive. You can see in another facts actually we are seeing that like we try to see that lot of the new drugs, and this has been like you can see that it has been Naloxone has been FDA approved in 2024. This was how we used to do previously. The first line treatment, second line, third line. You can see the performance status is very good. Age is good, is able to tolerate Folfirinox. We used to do it. Then, if neuropathy is not there, I can go Gem Nab-Paclitaxel or Gem K. Like we may try to do some changes or a single agent gemcitabine. If you use a Gem Nab-Paclitaxel in the first line, the performance status is down, I may push the. This is the things we do practice. Failure to that, we may go with a liposomal irinotecan with a 5-flucoverine, or like you can oxaliplatin 5-flucoverine is to do it, and the next modified Folfox or Kepox. These are other regimens we try to do. Is you have to see that like more like sometimes performance rate is not good. You may just palliative care. Sometimes single agent gemcitabine was a older practice, or capecitabine. Later, if some of people patient performance status is maintained well and able to tolerate, you can go even it's not been exposed to platinum based treatment earlier. You would have tried with a platinum based treatment. Otherwise, the liposomal irinotecan based treatment. The now updated, what is the approval with the Nalirfax and other thing, what is the current treatment guidelines? You can see that, yes, similar to the previous one, but the first line management has become Nalirfax. Actually, good performance status is there to performance status up to 1. And even performance status is not good, like the FAFS 2 and high burden but disease there, we may use a nab-paclitaxel gemcitabine, or like you can use a liposomal. If this is the first line, we try to use it. A second line, based on the whatever the first line treatment is done, based on that second line treatment, and third line is decided. Still, there is a scope for liposomal irinotecan 5 regimen if it's not used in the first line, or even the third line also if it's not being used actually. This is the NCCN guidelines in 2024. But the first line treatment, you can see is a category 1. You can see that modified the Folfirinox also was there, or modified Folfirinox. Nalirfax is category 1 is there. This is one of the thing, and Nab-paclitaxel also is a category 1. This has been FDA approved in 2024 in the metastatic disease and local advance also. This is the regimen Nalirfax is there along with the other regimens. You can see that the protocol, that is the study, that Napoli 3 study. You can see it is a open labeled phase 3, the global study. The Nalirfax, that is versus the nab-paclitaxel along with the gemcitabine in the treatment name advanced metastatic pancreatic cancer. You can see here like Nalirfax was integrated based on the ESMO and NCCN guidelines, and this has been approved by EMA and FDA also. You can see the advanced pancreatic cancer, that based on the performance status, how we manage actually Nalirfax, like you can see that only single agent gemcitabine or gemcitabine single agent, based on this is the category, the evidence is there for this move, the guidelines is there. And if the performance status is down, you can go only single agent gemcitabine. And here also similarly, that even if the bilirubin is abnormal, you may modify the treatment with a modification of the gemcitabine. Preferably that Nalirfax, wherever a possibility is a performance status, we can use it. That is the preferred one. Now, you can see here this is the study design. This is the confirmed of pancreatic advanced cancer, not previously treated. It's a first line setting, metastatic disease within the 6 week prior to we did not done any treatment. Screening is up to 6 weeks, and with the metastatic measurable disease. That is a total almost 770 patient with 1:1 arm, the Nalirfax versus the Nab-paclitaxel. This, what are the schedule, what is there practically, I think many of us that we may not practice day 1, day 8 and day the 2 weeks gap because of the tolerance is not easy here this regimen, but still we modified actually our day-to-day practice. And also Nalirfax, you can see liposomal irinotecan 50 mg per meter square, 5F is 2.4 gram, leucovorin oxaliplatin 60 mg per meter square. That is the one thing, because if you go Folfox directly, the dose may be different, and it's easily is able to tolerate this regimen. And coming to the end point of the study is the overall survival rate as a primary endpoint, and second endpoint is a PFS, overall response rate, and as per the RECIST criteria with the quality of life and biomarker assessment. You can see the baseline characteristics of the patient in the almost 770 patients. You can see Nalirfax arm versus the Nab-paclitaxel. You can see looking at the age, gender distribution, performance status. You can see they're all well matched actually. And the number of the site of metastasis, you can see single or like 1 up to 2 or more than 3. Also liver metastasis, you can see almost 80% of patient had in both the side. And even the tumor marker elevation also seen more than almost 80% of the patient. And also you can see the tumor location also, geographic distribution also, they are well matched. This is the patient characteristic that once you expose to this regimen, either Nalirfax or Nab-paclitaxel, you can see the discontinuation rate also, you can see less with the Nalirfax versus the Nab-paclitaxel. And progression of disease also is like relatively less actually. Adverse events also you can see appears to be less. And coming to the median OS with this NALIRFOX, you can see 11.1 month versus the 9.2. You can see the graphs are separated. Hazard ratio is 0.83. And you can see the subgroup analysis in the OS. You can see that all the thing. You can see that all the like the number of metastasis site and race, gender distribution, site of the message. You can see all it favors towards the NALIRFOX. And updated analysis you can see here. You can see that almost median OS is 11.1 months versus 9.2. And you can see other regular interval actually 6 month, 9 month, 12 month, 18 months. You can see still favoring towards the NALIRFOX versus the Gem/nab-paclitaxel. Tumor response also you can see here. The response rate is better, 42% versus the 36%. Complete response, more of partial response you can see with the NALIRFOX versus the Gem/nab-paclitaxel. And duration response also better. And modified you can see median PFS with as per the investigator you can see is better with the NALIRFOX 7.4 versus a 5.6 month. Hazard ratio is 0.69 and as the graphs are well separated, it is statistically significant. Look at the quality of life. It's not like that any treatment, any regimen is there. The quality of life also matters here. Those who are exposed to this NALIRFOX, you can see that the global health status score was maintained. It's like it's not deteriorated. You can see 15.4 months with the NALIRFOX versus the 12.2 months with the Gem/nab-paclitaxel. It was hazard ratio was 0.74. At serial interval also you can see that it's favored towards the those are exposed to the NALIRFOX. Quality of life is longer maintained in this NALIRFOX. And you can see that adverse event that is important when you're dealing with any regimen. That toxicity is also important. Hematological toxicity with modified NALIRFOX, you can see that NALIRFOX definitely is more favorable compared to the Gem/nab-paclitaxel. You try to see the more of hematological toxicity. NALIRFOX, you can see the more of that neuropathy related to oxaliplatin and other things you are able to manage. They're like you can easily manage, and the grade 3 toxicity you can see that they are all not higher actually. And subgroup analysis, you can see that like looking at the baseline characteristic, all the thing they're all generally well balanced between the NALIRFOX actually. That because we are worried actually elderly people can give it or not. If you see that more than 65 elderly people also, you try to see that the characters are well matched here. Above 70 years also overall population also. There also you can see OS is favoring towards the above elderly people, so that 65 years and even above 70 years also you can see it is increasing in the trend in that age people also can this regimen is favorable. And also you can see that the safety data in this elderly people, you can see safety also is there are not much any added toxicity. There are like even though the diarrhea was slightly more with this and the neuropathy. Other than this one, I think this is all expected side effect. Gem/nab-paclitaxel, you can see that more of hematological toxicity in the elderly people. Coming to that we are having then the era of the precision oncology. We will try to see whether the targeted drug level is there or not. Even though RAS is there, hardly will see that KRAS G12C, hardly few percent of the patient. Not even the KRAS is there, we cannot block actually. They're still in experimental phase in the clinical trials. You can see that there are other like target therapies we appears to be promising, but we don't get this positivity in the pancreatic cancer. Hardly very rarely we can once in a while we may find this one. MSI immunotherapy can give NRG1, RET, NTRK, other thing is less than 10% of people. Your biomarker important thing is about the MSI, BRCA, that is the one thing. HRD also some people they started doing in the pancreatic cancer also. But this is the one thing, KRAS is there, but the percentage is hardly less actually. Coming to does the molecular targeting, that's like because if you see that does it impact actually, definitely the molecular target therapy matched definitely gives the good outcome, but only thing is hardly finding a target in the pancreatic cancer. That is more important actually. We hardly, if you do NGS, all the things we'll see targetable actionable mutations will see less than like 30% of the patient. And drug also is very rare actually. You can see that the prognostic factor, clinical and biological factor, you can see that age, performance status, baseline CA19 national factor, number of site of metastasis, and various factors are there. And pathologically, you will see that These are things are there are the favorable targets are there you can manage. Otherwise, cold tumor, other things like immunological desert tumor is very difficult. We might just landing with the only chemotherapies. We'll try to have a short-term disease control. Coming to the Nalang study, that is one thing that is this is a real world evidence of the because the clinical trial we have a selected fixed patient and you have the criteria sustained. You can see the fit patients because real world evidence is out of the trial. There are even not eligible. Does it treated in a similar way, similar to the clinical trial, still have an impact on the how is the impact on the real world patient? That is this is the study is going to give the confidence to us actually. This is the one of the study from the Nalala section. You can see that in advanced pancreatic cancer and data and prognostic factor in the long-term survivor people and also the strong interest to learn and deeper in the longer survivor was done here actually. The real world evidence those are survived more than 1 year was analyzed. These are the countries retrospective multicentric study. You can see Japan, South Korea, Asian people also and European people were there from the 2018 to 2021. This is like the retrospective analysis was done. You can see here like almost 17 center, 163 patients were included here. This is like people are like survive still 20% of patients still alive at the end of the study. You can see here that is more important and at least one cycle of liposomal liposomal irinotecan was taken. Those people are eligible to take into their survival analysis. You can see that the different sites and patients, all the things were there. Like this is initiation of systemic therapy liposomal after the post gemcitabine who are
Sorry
eligible
to
for.
interrupt in between, sir. In sort of
Yeah,
time, I
yeah.
request you to please conclude in 2 minutes.
Sure. Yeah. This is the like I'm having just 2 slides actually. That this is the distribution of the thing. The results like it is like is able to like this is controlling this as a second line with this regimen, and median duration of response is almost like 8.4 months, and overall survival rate is also like try to like improvement in this regimen, and you can see almost like 21 months survival rate is seen with this regimen. That is from the second line regimen and from the diagnosis 34 months. This is very encouraging. Conclusion from this, the subgroup analysis favoring the overall survival rate, people are still able to do those who are exposed to the liposomal irinotecan, but requires more in-depth analysis actually. That is median overall survival is compared to the long-term those who are treated with Napoli-1 survival actually, and because require our Indian data also required more actually like similar to the real world evidence and experience of Indian consultant actually. Now I'll stop here. Like any questions are there? Like we can able to take actually in the panel discussion. We'll try to discuss on the liver cancer. So this is the important. This is the nalrefax is very important regimen in the management of pancreatic cancer other than our conventional drugs. Thank you. If no
Can I share
questions,
the
either
slides?
I'll request Dr. Murali Subramanian sir to moderate the panel discussion. Over to sir.
Thanks, Satish. Allow me to share the slides.
Sir, you are sharing or like you want
I'll
to
share.
take it?
I'll share.
Okay, yeah.
I'll share. Can I? Is it seen?
Yes, sir, it's visible, sir.
I don't know which slide it started. Just a second. Yeah, let's go to the first slide. Yeah. Thanks, Satish, and thanks for the organizers for giving this opportunity. We've had 2 presentations, one on the strides and then favoring the strides, and Dr. Rajiv presenting on the real world data of use of atezolizumab. I think all the panelists are present, Ravi, Satish, and Lokesh and Vinayak, right? I saw them. Yeah. So let's quickly, I'll
I'll skip few of the slides, maybe repeat. So this is the whole landscape of treatment for advanced HCC. As we all know that all multiple guidelines are now updating right from 2020, Atezolizumab as the standard of care. Alternate options being Durva-Tremi, and then TKI like sorafenib and lenvatinib comes as other alternate options. And it's very what to do after you use an IO-VEGF or an IO. That's becoming very, very challenging. I see the molecule lenvatinib is dying. So an excellent molecule which is dying, we'll look at that also. So because we are losing the option of using this molecule in the frontline setting because of the IOs, and then the second line options subsequently are becoming very, very different. We cannot use lenvatinib in this setting. So treatment goals, we have Dr. Srinivas has illustrated these slides. We classify based on the BCLC as B, C. A is very early. Probably we do not see BCLC A. They are available for resections and small local therapies. Most of our clinical practice are advanced stage, that is BCLC C. Very less we see BCLC B, which are available for local therapies like TACE combined with other systemic therapies. But most BCLC Cs, they go for primarily systemic therapies. We will look at these systemic therapy options and try to dissect out and try to make some sense about what is the possible best frontline therapy we can use. Slide is jumping. Okay. Okay. So this is kind of a timeline of all the phase 3 trials. I would just briefly run through that. 2007 was when SHARP came, and then IMbrave 150. I can call this protocol as a showstopper. Came in 2020, and then we have the Himalaya coming in 22, 23, and then we have the Checkmate 90W, which is also an IOIO trial. So Reflect is also an important trial which came around 2018-19, which is lenvatinib in frontline therapies. So let's start. First let's start with Dr. Ravi. How do you see HCC patients in your clinic? I mean, what are the challenges of selecting your first line therapy? Or if I put it, today there is a differentiation between NASH and the viral etiologies. At your clinic, how will you identify NASH when you see the patient?
Yes, sir. I think first thing is differentiating between viral and non-viral. Initially, we were very rigid because we used to think some work for only viral and some non-viral. I think now studies are there that both the frontline regimens, Atezolizumab and Durva-Tremi, both we can use it for viral and non-viral. That is one thing. The second thing is involving the hepatologist and see that when it is non-viral, so doing a fibroscan, what is the status of the liver and what metabolic treatment is required. So that is also very important. Then gastroenterologist see whether any varices is there or not. So that's the third point. And it's an MDT discussion between selecting, because nowadays we combine a lot of local treatment with immunotherapy. So I think all these regimens have moved earlier also. So I think we have got now some 2-3 good first line regimens and see that the pros and cons based on whether varices is there, what is a patient eligible for, whether is eligible for BEV or not. Based on this, we are taking the decision.
So excellent. So your emphasis on NASH versus viral etiology is less now as it was emphasized in the past. That's the take home I'm taking, right?
Yes, sir. Yeah.
Okay. Dr. Satish, what are your thoughts on the patient selection criteria? If you look at the how they select the patients in the clinical trials vis-a-vis how we see in the practice, is it any different or? Yeah.
Sir, etiology like the data is there for both viral and non-viral also. For atezolizumab and bevacizumab data is there. Like previously, that real world data also is convincing that we can use it. That is not pre-specified to do the study. That only subgroup unless they found that. The main thing is there, like I try to see whenever a patient is there, the patient is eligible to take immunotherapy, and the next one is the eligible to take bevacizumab or not. That's the one thing. And if anything is there, like because the viruses, all the things are there, we are able to rectify that banding, all the thing, we'll try to do it. The patient is high burden symptomatic and high risk categories, definitely I'll prefer the atezolizumab and bevacizumab. If the patient have a low burden disease there, then like I'll try to give options actually. That's like because like I want a rapid response means I'll try to go at bevacizumab and atezolizumab. The low burden disease there, I'll try to have the IOO therapy that I try to have. That's the other alternative option. And I don't think not eligible for bevacizumab, then the IOO therapy that I try to consider in my practice.
Lokesh, how is your baseline characteristics when you compare to trial in real world? Is it the same? You see more B and C, childpox B and C, or is it you see A? How is it? Is it different from the trial? Trial is a more controlled situation. Yeah.
Hi, sir. Yeah. Yeah, really the trial is more controlled. Actually, what usually we see is more of advanced disease. So more often we see patient with almost half of the cases will be in childpox B or C. And also we see more often the BCLC rather than BCLC-B. So almost 70% is BCLC-C. And even the main portal vein involvement also, I think it's in the study, it's around 20%, I remember. So we see even little more in our setting, especially in our institute. Most of the patients are in low socioeconomic background, and they're all come with a more advanced disease. So what usually we see in my setting is more of advanced diseases.
Right. Dr. Vinayak, do you have any other points about viral, non-viral, and then the patient characteristics baseline trial versus real world? Yeah.
So initially, I had this reservation about using IO in some selected patients, but I think overall data now looks like that all do benefit well. Only thing in autoimmune, I may be a little hesitant, but otherwise, I would go for all the cholestic disease.
Sounds good. Okay. So I'll quickly run through the IMbrave 150. I think we heard Dr. Raji talking about the real world evidence. This is the trial situation. Unresectable HCC, BCLC stage B, childpox A, good performance. It's very important to note that patients with main portal vein thrombosis were included. I think this is one of the drawbacks in the reflect lenvatinib trial, where the main portal vein thrombosis patients and major liver disease were not allowed. Here is a trial which has kind of included patients with all tumor characteristics. So it was a simple 2:1 randomization. Primary endpoints was OS and PFS. The OS hazard ratios was 0.66 and the PFS hazard ratio was 0.6. You can see on the right side the overall response rate was 30 versus 11 with a staggering CR rates of 8% and a disease control rate of 74%. So we all know based on this data, IMbrave 150, the atezobev is now the standard of care. We have other alternate therapies, strides we have discussed. We have now multiple immunotherapy options in the frontline setting. I will take one by one. Let's start with Dr. Vinayak this time. How do you interpret the OS data? We don't have a head-to-head comparison. How will you compare a strides versus a IMbrave 150? Do you use the Kaplan-Meier or hazard response rate? Or what is that you look in and how do you take a call as which patient should receive which regimen?
So first thing is like as of now, like last 4-5 years, data of atezo is so good, so it's very not so easy for let go of that bevacizumab arm. That's one thing. Coming to the science, that the curve suppression, other things, there are few subset of patients who do not respond so well initially, and I would not prefer IO. Otherwise, it provides with experience only you get to more use, but the stride dose, if I have to get it fully right, that the dose which they are given, if they can afford, I would push for it. Otherwise, I would not push for patients who cannot afford that. That's none of the parameters are there in the question. But definitely, I would prefer atezo compared to stride regime. But over time, I think I may choose on some patients, especially when patients with have bleeding tendencies, other things, I may prefer IO.
Right. Okay, this is how treatment is prioritized today. I mean, we look at in HCC especially a wide benefit, which has as Dr. Vinayak was saying, a high response rate. You're looking at longer PFS and a regimen which is less toxic. So, Dr. Lokesh, okay, there are now here 3 Kaplan-Meier curves. Very interesting. First one is right on top is the Atezo-Bev, and then the other 2 IO curves. One is the strides right at the bottom right, and the bottom left is the Nivo EP, which is from the Checkmate. Can you make some sense of these Kaplan-Meier curves?
Yes, sir. If you look at the first one, the Tezo-Bev, it is showing a very good suppression, maybe around 2 months. So maybe I think it is the bevacizumab is the one contributing to the response. I am not sure. Definitely, the other 2 curves we can see usually the responses are less when you come to use only immunotherapy. So that's what the curves continue to looks same. It's separating later. It is probably those patients who are really getting the long and durable benefit, getting the benefit in the end of the curve, showing the suppression at the tail. So I think it is the bevacizumab is the one which drives good responses in the early in the suppression of curve in the IM-Brave.
Absolutely. I think you have hit the nail on the head. If you want quick responses, I think Bevaz is the one which is acting very early, and the curves are separating very early, and then they're not looking at coming together, and the curve remain separated. And then at key landmark points, the delta is clearly maintained if you look at the Atezo-Bev. But the bottom 2 curves are the typical IO curves where you don't get that initial response. The thrust and the push was given by bevacizumab. You don't have that here in the double immuno, and that's why you have all those rapid progresses getting eliminated. And in fact, in the Nivo EP trial, you can see that the trial actually it's crossing over at some point also. This is a typical IO, as I call. Satish, do you have anything to add? Satish or Ravi? Yeah, I think this is the most important thing. Yeah.
Yes, sir. I think this is very typical of all solid tumor IOs, what we see. The biology plays a very important role in choosing IO.
Right. So now, I mean, cross-trial comparisons are hazardous. This is Atezo-Bev comparing with all other available data today. Here is a table, and I'll focus on the Vogel 2023 meta-analysis. First one is the A plus B versus sorafenib. If you look at the hazard ratio is 0.68. I think it's in line with the IM-Brave 1550. It's saying that there's a 96% chance of A plus B being superior. And as you compare to Durva plus Tremi, the superiority comes down to 70%, and it is almost 87% superior to the lenvatinib alone. So these are cross-trial comparisons from meta-analysis, but it's hazardous. But it's important to see one Chinese protocol here, the third one, which is camrelizumab plus Rivo. So here the hazard ratios are 1.09. I think this is the only one combination, I think, which is coming closer to Atezo plus Bev. And here the superiority actually falls down to 37% as compared to 80 to 100% with the other comparators. There is a lot of reservation from this. This is a Chinese study. I think it's more of driven by HBV serology positive patients. But nonetheless, it's an important protocol which comes close to Atezo-Bev in terms of being as good as Atezo-Bev. Yeah. So this is the response analysis. Needless to say, it's an overall response rate kind of protocol like lenvatinib. It's an overall response rate drug. If you get better overall response rate, it kind of translates into better survival benefits. So this also translates into the depth of response. It's much superior when compared to the sorafenib. This is clearly shown in this water plot. And And also the duration of response is also long with Atezo-Bev with a hazard ratio of 0.38. So it scores on 3 points, which has the higher response rate. The responses are quite deep, and having the Atezo in the arm, the responses are quite long also. So here is a protocol which kind of ticks all the boxes: response rate, depth, and durability, and hence it becomes such a powerful frontline therapy in unresectable HCCs. So the major question, and the major push for these strides is the varices. So I'll ask Dr. Satish. So once again, how do you approach the patients with esophageal varices?
Sir, I'll try to, with the help of a gastroenterologist, actually. See, bandaging is possible in many cases. Actually, we have done quite a number of patients. We'll try to do the banding, and within 4 or 5 days, the trial says that we have to wait for a couple more weeks, actually. I think we have done started doing this about the post banding within 4 or 5 days. We can use the bevacizumab because there's no active bleeding anything. If it are like not only esophageal varices and that patient that child to the B and C, that will see that whether because other the coagulation factors are not in the good, and whether we are really that again the risk of bleeding still post banding also anticipating means I'll be a little bit worried. So that's what I may not put a bevacizumab in that situation. With the help of medical gastroenterologist, I try to decide actually. That's what is like. It is a multidisciplinary decision actually. Because during therapy, immunotherapy, some people they may deteriorate with the liver function alteration or that is also not only the bevacizumab, even IOO therapies also. We have to be very careful. That is the one day one counseling is very, very important. And definitely many patients, almost I can say around 80-90% of we are able to manage, but post banding we can able to take into the bevacizumab based treatments.
Yeah. So trial also indicating that even patients with varices, the median OS does not drop. Actually, it's at 17.7 versus 8.6 in sorafenib. Those with varices, and also the PFS and the overall response rates are also pretty much maintained. Even those patients with varices, as Dr. Satish pointed, it's very important that you have a controlled varices. You must have had a treated varices. You don't want to have a patient with an active bleeding. So those are the absolute contraindications for Atezo-Bev. So it's very clear that if you have a controlled varices, actually epistaxis is the most common bleeding event which is seen in Atezo-Bev. It's not the bleed from the varices. So it's important that you identify varices right at the beginning, and endoscopy is now a mandatory initial screening, so that if you identify any varices, you handle that, band it, and then I think these patients should be okay for starting Atezo-Bev. Dr. Ravi, any other thoughts? Varices, are you comfortable? Those which are treated and there is no active bleeding to start with Atezo-Bev?
Yes, sir. I am comfortable because we know that a lot of the time the fear of bleeding is varices, but the bleeding occurs because of other causes, underlying background cirrhosis. So we are pretty comfortable if the banding is done.
Excellent. So I think most of us agree. Let's come back again, Dr. Vinay. Does etiology matter while deciding the treatment? We have discussed this. We'll go through once again. Does etiology really matter in deciding the frontline therapy?
So I think except for autoimmune disorder where this is not controlled, there we don't want to prefer IO. And viral or non-viral or NASH or even other etiology, I'm not very choosy about the thing about etiology which helps it, but I'm preferring Atezo-Bev for most of the patients if they're not contraindications for bevacizumab. I think we will need to wait a little longer for the IO data to take the mainstream. Either that or the cost.
Yeah. So most of the trials are not designed to look at it from a viral, non-viral etiology. Most of it are kind of a subgroup analysis. Here we are seeing forest plot of hepatitis B and C. Top is hepatitis B and the bottom one is hepatitis C. You can see that uniformly all IOs, they work very well in viral etiology. You cannot deny this fact. They're all to the left of the unity, and they're working very well, except to the Cosmic 312 and then the Himalaya. I mean, strides, there is some suspicion of whether it is effective in HCV. If Srinivas is there, he can take this question. The hazard ratio is 1.06 in the strides regimen. I don't know whether it is it powered to address the HCV issue, but definitely it's crossing the unity, and there is some concern of the stride regimen in HCV positive. Hepatitis B and C, IMBRAVE 150 clearly, and most of the IO trials, it's to the left of the unity. Whereas if you come to the non-viral etiology, again, it's not a pre-planned or it's not studied in. Again, here in IMBRAVE, you can see that it is to the right of the unity in non-viral etiology. So these are kind of, they're not consistent, but there is something brewing that there is difference in response rates and outcomes in viral and non-viral. Right now, we are not able to identify that and stratify the treatment accordingly. As Dr. Vinayak said, it might kind of open up in the future. But as of now, there are no clear pattern. I will leave it to the viewer to see the slides and look at the forest plot. And then see in the non-viral etiology, there is something which is happening. So no clear patterns at this point in time. We need to be cautious in interpreting these. But there is something, at least for a hypothesis generation, there is something which is definitely there between viral and non-viral. That's how I see that. So, but the majority of them have concluded that it doesn't make a difference in terms of the PFS or overall response rate. It is the same across all etiologies. It has been looked up as a post-hoc analysis in IMBRAVE 150 also. So before I go, let's take it to Lokesh. How do you see lenvatinib as a molecule? Where is lenvatinib going now with the barrage of IO, VEGF, and then IO in the front line? Are you using lenvatinib at all? If the patient is affordable and able to take all the time, where is lenvatinib going now? Yeah.
Yes, sir. If patient is really affordable, definitely we will not choose it. So obviously the best choice for our patient, with our own experience also, it is the Atezo-Bev. I don't have much experience of using IO combination, but most of our patients will not afford for IO, so invariably they'll end up taking lenvatinib under the scheme.
Sorry to interrupt in between, sir. In sort of time, I request you to please conclude in 2 minutes.
Yeah. So I think your patients are not. I mean, they're still doing good with lenvatinib. I still feel.
Yes, sir, they are doing.
Satish,
yeah.
Yeah.
Dr.
Satish,
yeah, I may use it, sir. Like, I'm not telling that because there is a situation there, like bevacizumab, I'm not able to use it. Sometimes, like, we may use it IO with lenvatinib also. We have done some cases. And there are like situation we have used bevacizumab and this atezolizumab we used, and failure to that also we used the post that one. We added lenvatinib to the treatment. That is post progression to the first time also we used. And even the post progression to the IO therapy also, you use the continuation immunotherapy and IO, and sometimes even added a local therapy to control the symptoms and palliation. We have done so. There is a definitely we may see the progression. We might, as a newly diagnosed, yeah, there are patients they're not willing at all for any immunotherapy. There we use there are situation we have gone for the only single agent lenvatinib we have done. So yes.
I'll quickly run through. I think Rajiv has presented the real world. But for me, the biggest worry is all the three, be it strides or IMBRAVE 150, all have compared with the weak comparator arm, that is sorafenib. It's very unfortunate that lenvatinib just got the approval in 18-19. That's when these trials started recruiting. And there has been no trials comparing with lenvatinib. Dr. Ravi, how do you see that? How do you see these trials have been comparing with lenvatinib? How do you see that? Yeah.
Yeah, I think at the time of trial design, we should take it as a face value. But if you ask her now, I think a comparator should be lenvatinib. Probably still these IOs will make the cut and give us the survival benefit, but probably the comparator arm also they will survive longer.
So, lack of time, I'll quickly run through this slide. There is some interesting Taiwan studies showing very high median OS and 5-year overall survival close to 20%. So these are from real world. This gives confidence that this protocol, Adazobev, is a kind of a protocol here to stay for a very, very long time. So one last comment, Vinayak, you can take what has been your experience with BP4 patients, that is the portal vein thrombosis in the major trunk. Do you see any differences in the outcome? How is BP4 in general? I mean, you are cautious, or how do you approach BP4? Yeah.
I'm cautious for portal vein thrombosis part, but I have 3 patients who have done well. So those are patients who could not go for lenvatinib. They were agreeing for immunotherapy. So, but sometimes I do prefer lenvatinib. Sometimes for those patients. Sometimes if they are not very keen on pushing, because sometimes this thrombosis can outcomes are so bad. So we would prefer.
Absolutely. I think we all should look for main portal vein thrombosis. If it's PV4, the outcomes with any of the drug is not good. Of course, Adazobev has better outcomes compared to sorafenib in terms of response rate, OS, or PFS in compared to sorafenib. But in general, it's a bad prognosis clinical situation wherein having a thrombosis in the main portal vein. It's also important to note that Adazobev patients have a preserved liver function test. 70% of the patients have good liver function, and they proceed to second-line therapy. These have been published in many Korean and Japanese real-world data, and that's how this molecule is so important, and it's part of many of the guidelines. So this is my last slide. So it's an important drug for OS, and then manageable side effects, good quality of life, better PFS, overall response rate, benefit regardless of the etiology, and even the VPR status. Here, the VPR status, it's compared to sorafenib, it is better, but VPR is VP4 is generally a poor prognostic factor, and it preserves the liver function for subsequent therapy. Thank you.
Thank you, sir, for excellent moderation on management of HCC. I request our next speaker, Dr. Rajiv LK, to speak on the management of esophageal cancer with torilumab. Over to Dr. Rajiv. He's a senior medical oncologist practicing at Kithwai Memorial Institute of Oncology. Over to Dr. Rajiv. Raju, are you sharing your slide or you need help?
I'm audible. Hello.
Yes, you are audible. You can start.
Yeah. Good evening, all. At the outset, I thank Satish for giving us this opportunity. And these are slides from the Reddies. So my topic is on redefining the role of immunotherapy in advanced esophageal squamous cell carcinoma. We know the global health problem. It constitutes almost 500,000 new cases per year, and it scores 11th most common cancer in the worldwide. And of course, it is the 7th most common cause of death. So if you see the graph here, it is the dark lines are the highest incidence. So coming to the problem in our country, so the incidence of esophagus, it's ranks 5th, even in the new cases and in the death, and even in the 5-year prevalence also, it scores the 5th most common cancer. So coming to the PD-L1 as a biomarker, as it is a very heterogeneous, it is a different attacks, different antibodies also. There are inter-observation observer variations also, heterogeneity in time and tumor location, and testing on topic. It is an active investigation. So we all know about TPS, CPS, and TAP. So I will not be detailing on this. So this question is always there. So going back to our today's topic, this is the ESMO guidelines. So we all know this. So it is a PDL1 driven in the advanced esophageal squamous cell. If PDL1 is positive, so what ESMO recommends, if it is CPS more than 10, pembrolizumab with chemotherapy, and PDL1 TPS more than 1%, nivolumab or chemotherapy or nivo-EP. Or if it is a TAP score of more than 5, that is slave with chemo as the option. But if coming to the PDL1 negative, again the chemotherapy is the option. So there is a role of tislelizumab or nivolumab also. So this treatment is based on PDL1 positive levels. Coming to the first line studies of the immunotherapy in esophageal cancers, this is the one study which is in 2021 ASCO. So this is a keynote 590. So you can see that pembrolizumab was used with cisplatin 5FU. The benefit was most pronounced in PDL1 CPS if it is more than 10%. You can see the cartoons here, the all comers versus the PDL1 more than 10%. It is almost as a ratio of 0.72 in the all comers. And coming to the PDL1 more than the CPS 10, it is 57.57 of hazard ratio. Coming to the next study in the first line, it is a checkmate 648. Again, here it is a nivolumab with chemotherapy. Again, here this also goes with the PDL1 driven. If the TPS is more than 1%, we can see here OS and PFS are better with TPS more than 1% compared to the all comers. So today's topic, that is the toripalimab, and that is the Jupiter 06 study, which is used with the chemotherapy in the treatment navy, that is in the first line, advanced esophageal squamous cell carcinoma. This is a phase 3 multi-center trial. So they included 18 to 75 years locally advanced cases, and they have included more than 6 months of relapse also. And only thing is there are no clear use of immune checkpoint inhibitors. So they randomized 1:1 with toripalimab with chemo, and stratification factors for prior radiation and the PS. So the toripalimab is continued 3 weekly, so till they tolerate, or up to 2 years they have given. The primary endpoint is PFS and OS and the many other secondary endpoints. Coming to the baseline characteristic, you can see almost they have included 40% are 60 more than 65 years, fairly well matched thing, and more of 85% were male. And if you come to the metastatic, 80% were metastatic. And if you see the PDL1 expression, again, the PDL1 below 50, just to remember this, below 50, below 10 was 50%, almost above 10 were almost 45%. So what is the result? There is a 42% reduction in the risk of progression of death. That is the PFS benefit that Jupiter 06 has shown. You can see, appreciate in the cartoon also. So if you see the median progression-free survival, it is 5.7 versus 5.5. But if you come to the 1 year progression-free survival, it is 27.8% versus 6.1, with the hazard ratio favoring the 42% reduction of risk in progression to the death. Coming to the subgroup analysis, so in this Jupiter 06, you can see most of the subgroup, they favored the toripalimab arm. So irrespective of the age, only the females and the patient who has received chemotherapy, radiation therapy, or on the line. So rest have the better benefit here. coming to the post-hoc analysis of this study, according to the PDL1 TPS subgroup, if you see this cartoon, if they have stratified according to PDL1 more than 1% and below 1%, so you can see the appreciate here. So the 1 year PFS rate is huge. The OS of 1 year is 28. Sorry, PFS 28 versus 7.6. We come to the OS of the same post-hoc analysis. Again, you can see there is a 42% reduction. That is the hazard ratio benefit was seen. But if you see the irrespective of the CPS, more than 1 or below 1, almost the hazard ratio is same, 0.61. So this was statistically significant. And coming to the updated analysis in the Singapore ESMO, if you see this, there is a sustained survival benefit was seen at 2 years and 3 years. It is at 2 years, it is a 27 versus 39, and 3 years, it is a 20 versus 30 almost. So with a significant PS, the median OS was around, if you remember here, 13 versus 18. It is easy to remember. So at 3 years, OS rate versus 20 versus 30. That is also, you can see that this is the updated OS data when presented in Singapore ESMO 2025. The same results, subgroup analysis, again, it is consistent with the previous reports also. Most of the subgroups were benefited with the molecule. So coming to the post-hoc analysis, where they have seen the OS here. So if you see the OS again with the PDL1 more than 1 versus below 1%, again the PDL1, irrespective of the PDL1, the benefit was seen. And at 1 year, if you see the 1 year OS rate, it is 47 versus 67. That is 20% benefit was seen. So if you come to the tumor response rates, again, if you see here, the toripalimab best overall response was 63% versus 62%. But if you see the complete response, it is more. It is 11.7 versus 7%. And even the partial responses were in the high. So if you see the overall response rate, again, it is better in the toripalimab arm. It is 69.3 versus 52.1%. Again, the disease control rate was in the highest side. Again, statistically significant 89 versus 82, and duration of response was also higher side 5.6 versus 4.2 statistical significance. The tumor response with toripalimab versus the placebo, again, irrespective of the TPS1, the response was seen 74.4% versus 54, that is 20%. 20% improvement was seen in PDL1 negative group in the toripalimab arm. So that is one important thing, the safety. Most of the safety, especially the grade 3, grade 4 were in the hematological like anemia and leukopenia and neutropenia. Rest are, you can accept the other safety profile. The conclusion of Jupiter 6, the toripalimab offers statistically significant and clinically meaningful OS benefit. And the addition of toripalimab to the chemotherapy in the first line has increased OS, that is median OS of 17.7 versus 12.9 with a hazard ratio of 0.72, significant PS. Notably, the survival benefit was significant greater in PDL1 status, that is regardless of PDL1 status. So maybe the toripalimab is a next generation PD-1 inhibitor demonstrated superior efficacy versus chemotherapy irrespective of the PDL1 status. This is a cross-trial comparison of the OS data analysis. So if you see the PDL1 cutoff, so again the toripalimab arm you can observe here. So the OS in the other things, irrespective of the PDL1, the toripalimab has benefited. But compared to the other Nivo, Pembro, or Twisted, they depends on the PDL1 expression. So this is one meta-analysis from the clinical benefit PDL1 antibody. This post-hoc analysis of Jupiter-6 provided evidence for supporting the superiority of toripalimab. So further, they have done the meta-analysis of this. The toripalimab performs better than the nivolumab, regardless of the OS, regards to OS, PFS, and overall response, even in the group of PDL1 below 1%. So you can appreciate in the CORD2. So the toripalimab, that is Jupiter-6, has benefited here. Coming to the
Sorry to interrupt in between, sir. In sort of time, I request you to please conclude in 2 minutes.
Yeah. So this is toripalimab performs better in pembrolizumab or nivolumab, even in the PDL1 below 10% subgroups. To summarize this, the Jupiter 06 demonstrated that regardless of PDL1, the toripalimab benefited with the PFS and OS. In the post-hoc analysis, toripalimab with chemotherapy was superior to chemotherapy, and the meta-analysis also showed significantly better OS and PFS in overall response. So, and these pooled results supports the superiority of toripalimab combined with the chemotherapy. This is the comparative analysis. Again, the benefit was seen here. So the EMA granted the marketing authorization for toripalimab in ESMO. So these are the molecules approved in the EMA guidelines. The EMA toripalimab, irrespective of PDL1, can be used. Tisley, you can use TAP score more than 5. Pembro, if it is CPS more than 10. Nivo, if it is TPS more than 1%. So I end here. Thank you for patient listening. Thank you.
Thank you, Dr. Rajiv, for excellent talk on the role of toripalimab in esophageal cancer. Definitely is taken all over the other molecule in the esophageal cancer. We accepted in the nasopharyngeal cancer. We know that data is there for pembro and nivolumab, and still that other things we are accepted already. I think here also that you are told irrespective of PDL1, even low PDL1 expression also is showing the superiority compared to the other molecule. Yeah, other molecule is there, but only thing is there they're having the PDL1 expression more than 10, 5, all the things. Yeah, is it? Yes. Definitely that is definitely. Already we are already using in this molecule in esophageal cancer, getting excellent result. Any questions in the from the audience? Anything? Because already we are ahead of the time. And I request, thank you, Dr. Rajiv. I request our next speaker, Dr. Supreet. He's a consultant medical oncologist at Sri Shankara Research Hospital. He's going to talk on the role of neoadjuvant therapy in gastric cancer with importance to the immunotherapy, the chemoimmunotherapy in gastric cancer. Over to Dr. Supreet.
Thank you, Satish sir, and thanks to AstraZeneca for giving me this opportunity. Hi all. So as Satish sir was saying, I would be speaking on the role of perioperative immunotherapy in gastric cancer. I'm sharing my slides. I don't know what happened. So I request the organizers to please share my slides. Yeah. So yeah, next slide, please. Okay. So this is the discussion outline. Initially, I'll be talking about overall gastric cancer burden, the current management of resectable gastric cancer. What is the role of perioperative immunotherapy, where all immunotherapy has failed earlier, and what does the Matterhorn trial say, and the final grand summary of all these trials. So if you see, we all know that the gastric cancer burden has been increasing year after year. Earlier, what used to be a phenomenon in the West or in the Japanese population, we are seeing more and more in India. And unfortunately, it is shifting into the younger population. What used to be an older population phenomenon earlier, and same holds true for other GI malignancies as well, unfortunately. Now, in India, we know that most of our patients present either in stage 3 or stage 4A disease. This talk is pertaining to stage 2 and stage 3, which is resectable gastric cancer only. Now, yeah, this is another important data wherein we know that no matter what we do, we offer surgery, we offer chemotherapy, adjuvant chemotherapy, or perioperative chemotherapy, invariably a significant number of patients come back with recurrence. Given the disease biology of gastric cancer, we have been trying to categorize these patients to understand who are the patients who should receive more intensive therapy versus less intensive therapy. Unfortunately, the molecular classification that came out a few years back also did not help us much in this regard. So what we have so far, if you see the evolution of chemotherapy in gastric cancer, in early gastric cancer, it all started with the MAGIC trial, wherein patients were randomized between surgery only versus perioperative chemotherapy, and it demonstrated that perioperative chemotherapy gave PFS as well as overall survival benefit. Then came, remember, we need to remember the fact that patients in MAGIC trial received ECF or ECX-based chemotherapy. Then came the landmark trial of FLOT4, where it was compared with the MAGIC regimen, and it has clearly shown overall survival, disease-free survival, as well as pathological complete response with the FLOT regimen. And this kind of put a full stop to the role of anthracyclines in gastric cancer. And so far, FLOT has been the standard of care for almost 8 years. It remained unchallenged. There were various trials that came escalating FLOT, but it remained unbeaten. But now we have something, we have a new drug that has done that. But before that, we need to look at how FLOT is administered in India. I believe most of us would not be very comfortable offering our patients with a 24-hour 5FU infusion, which is what is the original FLOT design is. So there is data for modified FLOT where 5FU is given at 2,400 milligram per meter square over 46 hours, and that also has shown better tolerability with similar efficacy. And therefore, I think, especially in elderly population, I personally am comfortable with modified FLOT rather than the original FLOT regimen. And this was another comparison between FLOT versus EOX. Again, FLOT was found to be superior. This is just to understand the prognosis. Proportion of patients who achieve pathological complete response with perioperative FLOT is as meager as 8 to 14%. There was always a need for some improvement in this regard, because we all know pathological complete response is a surrogate marker for survival outcomes in a lot of malignancies. Now, perioperative immunotherapy, we all discussed this in most of the malignancies. The same is the rationale in bladder, lung, head and neck cancer, breast, triple negative, etc., where you have the tumor in situ, so there is more neoantigen release. Because of chemotherapy, there is tumor destruction, there is more antigen release into the circulation, better immune responses, as well as when you are administering immunotherapy, when the tumor is in situ, you have better priming of the immune cancer-specific immune cells that go and fight against the cancer. And then we all know that PD-L1 is one of the surrogate markers or predictive markers for response to immunotherapy. In advanced stage, we have approvals based on PD-L1 CPS 5 or more for nivolumab, or PD-L1 CPS 10 or more for pembro, and 1 or more for tislelizumab. These were the various trials that used immunotherapy in early stage gastric cancer. First came Keynote. First, I believe, was Attraction 5 trial, where the patients received perioperative chemo followed by adjuvant only nivo. but unfortunately this trial was negative for both PFS and overall survival data. Then came Keynote 585. Here again, the trial was negative for survival outcomes, though it was positive for pathological complete response. But I believe this is more to do with the trial design rather than the differences in the drug as such. And then came Matterhorn trial, which is going to be the current point of discussion in this presentation. So before that, Attraction 5 was, as I said, an adjuvant-only immunotherapy trial after the patient has received post-operative chemotherapy or adjuvant chemotherapy. And as I said, it was a negative trial. Same was pembrolizumab. If you see, a lot of patients in this trial received just a doublet as chemotherapy backbone, which was 5-FU plus cisplatin or capecitabine plus cisplatin. But we know that that is not the standard of care in gastric cancer. Unfortunately, as I said, this trial was negative for both EFS and OS. Then came the Matterhorn trial, which tested the role of addition of durvalumab to FLOT in perioperative setting. The comparator arm was just FLOT, 4 cycles before and 4 cycles after the surgery, while durvalumab was given for a total period of 1 year. As you can see, patients included were those with T2 or more or any node-positive disease. PD-L1 expression status was used as a stratification factor, but I personally believe it doesn't matter much in perioperative setting. The primary endpoint was the EFS and secondary endpoints were OS and pathological complete responses. Now, if you see the study population, almost all patients completed FLOT before the surgery, even in the durvalumab arm, and equal number of patients went on to undergo surgery in both the arms, and almost equal number of patients completed the adjuvant phase of treatment as well, which goes on to suggest that durvalumab is not adding to toxicity much in this setting. Then you have the tumor site. Then you have the data of tumor site. Majority of the patients were having gastric subsite. A significant number of patients also had GE junction origin tumors. A large number of patients had T4. At least 1/4 of them had T4 disease, which is the kind of real-world situation that we encounter in our country. PD-L1 less than 1%, not much, around 10% of the patients. So we cannot derive much conclusion from this particular subset. And deficient MMR is something that we barely see. I personally haven't seen any or maybe I can remember only one patient of deficient MMR gastric cancer that I have seen so far. But around 5% were there in this particular trial. If you see the primary endpoint, it was achieved at the end of 2 years. There was an absolute benefit of about 9% in event-free survival. It was favoring durvalumab plus FLOT arm in all the subgroups that were analyzed. Then even overall survival delta was about 6.7% at the end of 3 years, with 22% reduction in the risk of death. Again, same. Almost all subgroups had overall survival benefit, though we know that OS data is not mature yet. Now, PD-L1, as I said, it doesn't matter much because patients who had PD-L1 negative disease were very few, but those who had positive disease had significant overall survival benefit. Now, pathological complete response rates, if you see the delta is around 12%. What was 7% with single digits in with chemotherapy alone has now become double digit. I'm looking forward to addition of another agent that would increase this even further. But for now, what we have is durvalumab plus FLOT is the best regimen that we have in this setting. Now, common adverse events, we all know the adverse events caused by FLOT. They would be hematological, diarrhea, mucositis, etc. As such, I don't find durvalumab to be toxic. Personally, I barely have come across any patient developing even hypothyroidism with durvalumab. So there, I would say it is very well tolerated drug. And to conclude, as I said, gastric cancer is ever increasing in incidence, and it is shifting towards more and more younger population, where there was always a need for improvement. Oflot has been the standard of care for about 8 years. Various adjuvant-only immunotherapy approaches failed. There was one trial with perioperative approach with pembrolizumab that again was a failure. Now, for the first time, we have a positive trial in perioperative setting in the form of Matterhorn, and we are happy to change our practice and accept durvalumab plus plot as the current standard of care. And the 3 Fs of Matterhorn, I honestly didn't understand what is Plexi plot, but we know it is a finite duration treatment, and it was the first IO with meaningful EFS and OS. With this, these are my declarations, and I thank everybody for patient listening and AstraZeneca for this opportunity. Thank you.
Thank you, Dr. Suprit, for excellent and crisp talk on the perioperative region on gastric cancer. You made a clear points. Any questions from the audience? Like, I think we are in final conclusion part now. Any questions in the chat box? Anything? Thank you, Dr. Suprit, for the really excellent. Like you have made a clear, like that's on. Even though other regimens are doing well, still be the maybe the design error, the statistical, because pathologically that you are told, because we are seeing like pembro is like it's been other disease working here. Why that's maybe the regimen we have to see in depth. Actually, we have to dissect and we have to see that. Yeah, definitely this the Druva data is very impressive. The flat regimen. Okay.
Yes,
Thank you.
I believe they made a mistake of using the wrong chemotherapy backbone. That was one of the reasons. Yes, sir.
Thank you. Thank you.
Okay, sir.
Thank you. Thanks all the faculties like they presented the excellent like support, and they made a valuable information to audience and even exchange of knowledge. And also experience of each like a colleague and senior medical oncologist and learning from one another. I learned a lot, and thanks all the speakers and the panelists and moderator and even the organizing team and the technical support. My sincere thanks for excellent conducting this today's CNE. Thanks everyone, and request I'm handing over to the organizer to anything you wanted to say. Thank you.
Thank you everyone for joining and give your valuable time. Thank you so much. Technical team.
Yes, ma'am.
Please end the meeting.
Okay, ma'am. Thank you.
Good night, everyone. Good night.